So I now declare the meeting of the Health Committee open to the public online. I would like to welcome all members who are participating by video conferencing this morning, and this morning that is Colin McGrath, Paula Bradshaw, Caroline Killen, Pam Cameron, Rqia Flynn, Alan Chambers and Deborah Erskine. And I would like to remind all members about the protocols regarding the use of electronic devices. So we have full attendance this morning. In terms of chairperson's business then, first of all, I would like to very much welcome a constituency colleague, Deborah Erskine, to our Health Committee meeting here this morning to Fáilte Road. Deborah, you're very, very welcome to the committee, and I'm sure that myself and all committee members will extend all help and support to you. It is a very busy committee, and we appreciate your contribution to it. I would also like to thank you, Deborah. I would also like to thank Jonathan Buckley for the work that he has done on the committee, and I think we all agree that Jonathan certainly was a very capable member, came in at a very busy time as well, and contributed, I think, greatly to the committee's work as well in terms of detail and his passion for the issues. So I'd like to thank Jonathan for that work that he has done. And the final point just within Chair's business that I want to touch upon is to highlight the fact that this is Ask Your Pharmacist Week. And I know, committee, we have met with community pharmacy and we've engaged with pharmacy, and I think we all agree that pharmacy plays a crucial and a very central role in terms of the healthcare overall system. I know as a rural MLA that very often in small villages, in places, community pharmacy is actually the only health infrastructure, and I think in light of that it is probably even potential for further kind of minor ailments work that could be done via pharmacy. They are on the ground, they do know the communities, and they play a very vital part. But I do want to emphasise the message of this week, which is, in the first instance, for minor ailments, sore throats, sore ears, some skin conditions, in the first instance, it's always worth asking your pharmacist, and they will at times be able to provide advice, and they will refer you on to the GP or whatever if that's necessary. The other important element, given the situation with COVID and winter pressures that we're seeing across the health system, is that they are offering and making available booster doses of COVID-19 to people who have reached the 6-month period since their second vaccine, and they're also providing the winter flu vaccine. So just to send that message out loud and clearly to people that that's one avenue for those things, and also for the minor ailments. So thank you for that. And members, draft minutes then, I refer you to the draft minutes of the meeting of the 21st of October, which are tab 3.1. Are members content with the minutes? Yep, content. Thank you, members. There are no matters arising then from those minutes. Item 5 then, members, we're moving on to our first briefing this morning, and this is a briefing from the General Medical Council on Neurology. I refer members to the Clerk's memo at tab 5.1 of the pack and to other papers at tab 5.2 to 5.8 of your pack. Included in the pack are briefing papers from the GMC and a written update from the inquiry panel, which we will return to after the evidence sessions. Representatives from the General Medical Council are here today to brief the committee on its role in investigating issues relating to Michael Watt. So I would now like to welcome to our meeting this morning by Starleaf, first of all, Mr Charlie Massey, who is Chief Executive and Registrar with the General Medical Council. Are you able to hear me okay, Charlie?
I can hear you fine. I'm hoping you can hear me as well.
Yes, we're hearing you loud and clear there, thank you. And also Mr Anthony Omo, who is General Counsel and Director of Fitness to Practice with the General Medical Council. Are you able to hear us okay, Anthony?
Yes, Chair. Good morning. I am.
Okay. So, listen, thank you very much, and I would just ask all members online to ensure that you're on mute when you're not speaking, as it can interfere with the sound quality. And also, if people have access to headsets, that often is much easier for all concerned. So that's helpful if people have access to that. But I'm going to now return to yourself, Charlie, just to see, is it you that's going to lead with opening remarks, or are you both going to do some remarks, and then we could maybe go to some committee questions?
Sure. So I thought, Chair, it might be helpful for me to start with some opening remarks, and then if I can turn to Anthony as we go through the questions so that we can field them between us. Does that sound okay?
It does indeed, and I should have actually said I want to welcome you both to committee this morning. So yes, absolutely. Go ahead then, please, Charlie.
Thank you very much. Well, it is actually great to be with you this morning, but I do want to start just by acknowledging the disappointment and anger that I know was felt by so many patients as a result of the decision by the Medical Practitioner Tribunal Service to grant voluntary erasure to Michael Watt. We at the GMC, and I think you've seen some of our statements, we're also extremely disappointed by that decision. It was not the decision that we wanted, and we completely empathise with the patients who we know felt very let down and understandably distressed. That hearing took place in private, but I can tell you that the QC who was representing the GMC in that hearing argued very strongly that the public interest meant that the case should proceed to a hearing. And when I saw that decision, I immediately sought external legal advice on whether that was a decision that we would be able to overturn. That legal advice established that we have no formal statutory appeal right of the decision that was made, so the only route available to us would have been through a judicial review process. But that judicial review threshold is set very high. In effect, we would need to demonstrate that the tribunal acted illegally or irrationally or in a procedurally improper way. In effect, that no reasonable tribunal could have reached the same conclusion. And the legal advice told me that we had no realistic prospects of succeeding with the judicial review, and I very reluctantly was forced to conclude that we would have no chance of succeeding, and therefore decided not to proceed with the judicial review, and I think you've seen our statements to that effect. Although the voluntary erasure therefore takes effect from the 1st of October and Michael Watt is no longer on our register, our interest in the case remains very high. We continue to engage with the department, the Neurology inquiry, and indeed Rqaa as the various strands of work progress. I would like to say to patients that I'm very sorry that we're left in this position. It's not the outcome we wanted, and indeed our focus on engaging and meeting with patients continues, and we've written to patients and engaged with them throughout, both when the Medical Practitioner Tribunal made that original decision and when we made our decision not to proceed with the judicial review. So I hope, Chair, that gives some useful remarks. I'm sure you'll want to get into some of the bits that I've talked about as we go through the session this morning.
Okay, thanks, Charlie. I suppose, first of all, I would, it is very disappointing. I think that the decision, that the course of action was taken, that the course of action was allowed to be taken, and I am really deeply conscious of the impact this has had, and we have all met with some of those who have been, many of those who have been impacted as a result of this very, very serious situation. And I'm conscious that those people are watching our committee today and are in a situation where they feel let down by the system for a long and an ongoing time, and that this is a further letdown and a further blow to their ability to see accountability and even the facts of the situation aired. And I know you have said that the legal advice indicated that a challenge wasn't likely to succeed. I suppose there's people would say that the challenge in itself would have been worthwhile and would have liked to have seen a challenge. I think that's fair to say. But have you communicated with the families as to the reasons for not challenging the decision?
So we've contacted patients and offered to meet. One of the challenges that we all face is that the Medical Practitioner Tribunal Service decided to have that hearing in private, and therefore the determination that there was a very detailed set of reasons that the Medical Practitioner Tribunal produced, but which they haven't published. And the fact that it hasn't been published, I know, has added significantly to the distress that patients faced. We have seen that within the GMC, that determination, and that was the basis for the legal advice that we received. My hope is, and I know this is actually the intention at the Medical Practitioner Tribunal Service, that they will publish a redacted version of the determination that will hopefully help patients understand better the rationale for that decision, but it remains a decision that we disagreed with. We argued that the public interest was such that this case should have proceeded to a hearing, which is what we and patients would have expected. So I don't know, Anthony, you may want to add a little bit insofar as we're able in terms of the reasons for the determination.
Thank you, Charlie. If I may, Chair, just to say on the judicial review, we did consider it very carefully. And it is the first time in the GMC's history that we have considered judicially reviewing one of our committee's decisions, shall we say. So it's not something we took lightly, but the advice, it was more than we didn't have a chance. It was that we had no chance of successfully overturning it. Our disagreement and disappointment with the decision was not grounds for doing so. As Charlie says, we hope that the MPTS will now publish a revised version, and we will be happy to meet patients to explore that further once that happens. We have made the offer to meet patients, as Charlie has said, and explain insofar as we can what has happened and what happens now, and we continue to engage with the inquiry and others in the health and social care system in Northern Ireland to ensure that lessons are learned and this type of thing doesn't happen again.
Okay, thank you. At what stage did the GMC become aware of issues in relation to Michael Watt, and what actions did you take when those concerns became clear?
I'll probably turn to Anthony to take us through the fitness to practice process with Michael Watt, if that's okay, Chair.
Yep, thank you. Go ahead, Anthony.
Thank you, Chair. So we were made aware of concerns in April 2018, and we immediately launched an investigation into those concerns. We imposed an interim order restricting Michael Watt's practice, and that was initially conditions, restrictions, and then suspension. And then we decided to investigate using what we call a performance assessment tool, which is a tool that allows us to look at the whole of the doctor's practice to see whether they're fit to practice. That assessment was completed in October 2018, and we referred the case to a hearing at the MPTS in February 2019. There were then several delays due to the doctors requesting postponements from the MPTS and the MPTS granting them. We were ready to go from February 2019 with the case. So I hope that summary gives you the start date of when we became involved.
And in relation to the annual appraisals, that process, what role does the GMC have in relation to overseeing the annual appraisals that in the case of Michael Watt were not done and actually is an element of this entire situation? So what's the GMC's role in overseeing the annual appraisals and the robustness and the efficacy of that system?
Sure. So the GMC has an important role in overseeing local clinical governance systems. We aren't responsible for the appraisal process itself, but we did in 2012 create a system of revalidation. What revalidation does is that it forces senior medical directors to essentially demonstrate that they are satisfied that a doctor is up to date and fit to practice. And part of what's required in terms of senior medical director being able to satisfy themselves about that is that those doctors have an annual appraisal. Before revalidation came into place, i.e. before 2012, there were a very large number of doctors, nearly half of doctors across the UK, that actually didn't have an annual appraisal. And one of the things that revalidation has driven has been a massive increase in appraisal rates. So we now have well over 95% of annual appraisals completed by doctors. In relation to Michael Watt, he was last revalidated in 2013, which was obviously very early in the days of revalidation. But the responsibility for that appraisal will have sat with the Belfast Trust, where Michael Watt was working, which was his, in technical terms, his designated body.
And then what is your role in terms of ensuring that trusts or the responsible body are actually completing those appraisals? And do you have a role to play? And have you engaged with the Belfast Trust around their failure to complete the process with Michael Watt?
Yes, so one of the things that we've set up within the GMC is a kind of outreach capacity. So over the last 10 years or so, we have very significantly increased the resource that we make available to engage with senior medical directors locally. Those outreach officers both engage about those doctors where there may be concerns about their practice with responsible officers, but they also have conversations about whether the local clinical governance systems are working well, and ideally we will be supporting those senior medical directors in terms of making improvements where that's necessary. As I said, the process of revalidation that gives us a real locus in terms of that clinical governance process began in 2012, and obviously a lot of the questions that I know the Neurology Inquiry are looking at relates to Michael Watt's practice in the years before then as well.
Okay, thank you. I'm going to go to members' questions now, but I maybe just want to suggest to members or propose to members that we write to the MPTS and ask for a copy of that report that has been referenced there, that's being completed. Members content? Yeah, thank you. Okay, so I have a number of members indicating then. I'm going to go first of all to our Deputy Chair, Pam Cameron, then I have Carol Nichillen, Jerry, Alan, Paula and Rqia. So I'll go first of all to Pam. Go ahead, Pam, please.
Thank you, Chair, and good morning, everybody. Thank you to Charlie and Anthony for your time this morning on what's a very distressing subject for so many people within Northern Ireland. I wanted to ask a few questions, if you don't mind, and I want to ask, in the experience of the General Medical Council, how unique is it for any doctor to be allowed to voluntarily deregister while he and his work are being currently the subject of a public statutory inquiry?
So Anthony may be able to give some more specifics about active inquiries, but it is generally a very rare thing for a doctor to be able to seek and get voluntary erasure while they're part of a wider process. There are exceptional reasons that are published that enable those decisions to be made to grant voluntary erasure and essentially remove the doctor from our register, but they are exceptional, and indeed we're very clear that we don't want or expect that voluntary erasure process to be a mechanism through which doctors can avoid going through that hearing process, which is obviously the issue in this case. But Anthony may want to just talk through those exceptional circumstances and the guidance that pertains, and perhaps Anthony, if you were able to explain the position we took in terms of the arguments we made around the prevailing public interest.
Thank you, Charlie, and start by saying we completely understand the disappointment and we share that and the frustration. Voluntary erasure is a process allowed in the legislation, and it doesn't preclude being granted when there's an investigation. As Charlie said, we obviously oppose it, and in this case we did. And members may know that this was the third application for voluntary erasure that was made during the life of the investigation. Our case examiners who work for the GMC had rejected the first two applications, and this independent tribunal granted it on the third go. As Charlie said, there are exceptional circumstances set out in the guidance which the tribunal had to balance against the clear public interest in this case, and I think they recognize that. So they're doing a number of things, and sometimes there are intentions. So the exceptional circumstances, and obviously I can't speak to this case directly, but in broad terms, the circumstances include the doctor's health, their vulnerability or risk of suicide, includes their ability to participate in proceedings. And then you look at things like the seriousness of the allegations, the stage at which the doctor is in their career and whether they'll return, how long they've been out of practice, and whether ultimately granting voluntary erasure ensures that the doctor won't practice and can't practice, notwithstanding that there may be public concern in other inquiries ongoing. So those are just some of the factors that need to be considered. And indeed, as we've said in our evidence, we argued strongly that the public interest overrode the other factors that were at play, and it should have proceeded to a hearing. But we did not succeed at the tribunal. And as I said earlier, for the first time in our history, our long history, we actually actively considered judicial reviewing the committee. We've never done that. So that I hope shows how seriously we take it.
Yes, I appreciate that. Thank you. Just some more questions for you. I wanted to ask if the GMC retains the evidence that they've gathered, and if so, what do they do with that? And also, can the GMC make their findings available to the public inquiry?
So the short answer is yes, and indeed we've already made that offer. Obviously, our locus to act ourselves in relation to a doctor requires a doctor to be on our register. So the fact that Michael Watt was granted voluntary erasure means that locus to act has been removed. Theoretically, it would be possible for Michael Watt to apply to be restored to our register at a future point, at which point all of that would come back into play, and we wouldn't allow him to come back onto our register until we'd been able to complete those processes. But we have said to the Neurology inquiry, we are very happy, as we have always been, to share everything we've got with them, recognising the constraints of the public inquiry, and indeed to the disappointment to patients that the public inquiry is not set up to explore the clinical failings of Michael Watt, and I think that is a kind of a gap that the decision by the Medical Practitioner Tribunal Service has left exposed. But yes, we will share that information not only with the Neurology inquiry, but also with the Department of Health and indeed Rqaa, because they both have live processes ongoing as well.
Thank you for that. Could I also ask you, will the GMC disclose to the committee the legal advice that they received concerning not proceeding with an appeal to overturn the MPTS? And if not, why not, as this would be within the public interest?
So I'll probably turn to Anthony to answer that one, because it becomes complicated because of the fact that the hearing was held in private. But Anthony, I think you'll be better placed to explain that than me.
So I think that is essentially it. The challenge we have is that the legal advice obviously is based on a decision that was held in private, and so it would be revealing matters that were held in private should we choose to disclose it. So I think it would be difficult for us to do so at this stage. I think it's something Charlie and I can have a look at when we see what the MPTS has released, and I know that the chair has called for that to be forwarded, and we'll make sure the MPTS has that request. Maybe it's something we can come back to at that stage.
Yeah, I mean, I could add, if I may, I mean, we would like to share with the committee everything we are able to legally. And I think one of the challenges we all face in this is the fact that because the hearing was held in private, the determination in full hasn't been published. And you know, that leads to enormous frustration on our part as well as with patients, because I would be very happy otherwise to share in a very transparent way the way in which we've approached that decision. But because the hearing was held in private, because that determination thus far has not been published, it does significantly limit in law what we're able to disclose, but all of our instincts and will is to disclose whatever we're able to do so, and we'll share that with the committee whatever we can, whenever we can.
I think that is to be much appreciated, and I hope there is information there that can be shared. I mean, this is such a serious issue, and so many lives have been destroyed on the back of misdiagnosis and mistreatment. I think, you know, there are so many people out there who are hurting right now, physically and mentally hurting, and people who've lost, you know, much of their lives because of the fact that they've been on wrong medications, which have actually damaged their bodies further. But I thank you for your time this morning.
Yeah, thank you. Thank you, Pam. Yeah, and there's so many life chances that have been destroyed as a result of this scandal has been shocking. The impact in both the scale and complexity of it is truly shocking. And in light of that, and in light of the fact that you have advised the committee that this is the first time you even considered taking a judicial review, so clearly that process has never been tested, and advice is advice. But I think firstly there may have been merit in testing it out because it's never clearly been tried before. But taking that as the situation we're currently in, if further evidence emerges either as a result of the MPTS report or indeed the neurology inquiry that's ongoing here, Are you keeping that situation under review, and will you re-examine judicial review if further evidence comes to light that may tip the balance?
Anthony may want to come back on that, because I think there are some timing issues involved in terms of the judicial review process as well.
Yes, thank you, Chair. So it is a good question. So I think there are two parts there. One is we have seen the full determination, and so there's unlikely to be any evidence around the issue of voluntary erasure that would change the advice. But the second, perhaps more important point that you make is, if there is other evidence that comes to light, then we're more than happy to play our part in, because I presume that will be about system learning and other learning for us and the system in terms of ensuring this doesn't happen again. So I think we will keep that bit on the review, but I think for judicial review, as Charlie said, we've got a hard 3-month deadline. But if we're going to do it, we have to do it promptly and in any event within 3 months. But because we've seen the full decision, there is unlikely to be anything new around that decision that would cause the advice to change or our decision to change. But the wider issues, if there are things that crop up, obviously the inquiry is still going, Rqia is investigating, and we are keen to make sure that we're part of any learning on that side of it. It doesn't help the patients who've gone before, but hopefully will prevent this happening again.
Okay, I'm going to move on then. I'm going to end to Carol Killen. Leanna Rai, leis Dukesh, Carol Lidhall.
So thank you, Chair, and thank you to Charlie and to Anthony for coming to the committee this morning. I mean, both Colm and Pam have set out what you already know, the distress and the trauma that these people are facing, and I'm sure you fully appreciate that every time something is mentioned in the media, it has a tremendous impact on people. But I can't help but feeling that, you know, in terms of any additional recourse, even through judicial review, that all these different processes are almost winding the clock down for these people, because you will also appreciate that the MPTS had their hearing in private. The public inquiry was going through public or its maximalisation process. There's an ongoing Rqaa inquiry, and while there's discussion around this, the public interest test hasn't been tested effectively, in my opinion. And the fact that, I mean, the MPTS is a statutory committee of the GMC. So, and that's where I find it confusing, even though it may be independent. But where is the public interest? How can you test the public interest of a hearing been done in private? That's my first question. And then secondly, and more importantly for me, do you believe that Michael Watt should be allowed to keep his pension that he's receiving from the Belfast Trust, given the fact that he's removed himself off the register? And then my last question is, it is rare for the GMC to make public comment of this nature, so I welcome the fact that you are not only sympathetic but supportive of the patients. But given all that, what recourse will be if something like this isn't tested publicly? You know, in other words, if the public inquiry, and as Colm and Pam have said, makes a report and it doesn't really address the concerns that have been raised, that you have seen, then what other recourse do people have if a judicial review has been closed down, other than saying this shouldn't happen again? Because that's not going to cut it.
Thank you, and I completely understand and agree with the comment you made at the beginning there in relation to the public distress. There are a few different questions, if I try and take them in order. One of the questions you raised was around the MPTS's role as a statutory committee of the GMC. And one point I know we've made this point publicly, but I did want to emphasise the independence of the Medical Practitioner Tribunal from the GMC in its decision making. It is a statutory committee of the GMC, but its accountability is not to me. It's through to the chair of the GMC and ultimately to Parliament. It is operationally completely separate from the GMC, with separate leadership under Dame Caroline Swift. And it effectively acts as an independent tribunal service. So both parties, when the MPTS is hearing a case, will submit their evidence. One of those parties will be the GMC, and the other party will be the doctor. And both of those parties then have a right of appeal on those decisions. Sadly, not this decision, if they disagree with that decision that's been made. So although it is a statutory committee of the GMC, although the GMC pays for the operation of the MPTS, I have no influence or locus to affect its decisions. And indeed, just to reinforce my disappointment with that decision, once the decision was made, I did actually write to Dame Caroline Swift on the 5th of October, and I said in that letter that I felt that the public interest ought to have weighed in favour of proceeding. Obviously, the hearing was held in private, but the question was about the public interest balancing against the private interest, and we were very clear in our view, and indeed our QC argued in that process that the public interest should have been overwhelming. I think the question about whether Michael Watt should keep his pension, I think, is a really good question. It's not a question for the GMC. I understand from my conversations with the Department of Health that in order for that to happen, there would need to be a criminal conviction for Michael Watt. I know you're taking evidence from the department later. You might want to just test and clarify whether my understanding on that is correct. But if that is correct, obviously there isn't a criminal conviction against Michael Watt. And if there was a process, obviously the GMC would be very happy to cooperate with that in whatever way it could. I think the other part of your question, and apologies if I'm misrepresenting this, was that the unique circumstances we're in here in terms of having even considered a judicial review might have weighed towards me making a decision to proceed in spite of the legal advice that I had. And I think that's a really great question. It was one that I did ponder quite deeply and discuss with Anthony, and indeed I also tested it with my counsel, although it is a decision that ultimately is resting with me in terms of the delegations to me as Chief Executive and Registrar. But the ultimate view I took was that the strength of the legal advice that basically said, I think as Anthony described it earlier, that we would have no chance of succeeding, meant that I took the view that it would actually been very misleading to patients to proceed with a judicial review that we thought we had no chance of winning. I think had we done that, I think we would have potentially created a lot of false hope and false expectation amongst patients, which I would have felt at the time would have been dishonest of us to proceed on that way. Of course, in terms of recourse for patients, I know that some patients and patient groups are considering themselves whether they would want to take legal action. The avenue open to them would be the same, a judicial review. Obviously, it will be for those patients and those patient groups with their legal advice to make a judgment about that. One of the challenges that they face at the moment is that, unlike us, they haven't seen the reasoned determinations because of the fact that the hearing was held in private. And so I hope that the intention that the Medical Practitioner Tribunal Service has of publishing a redacted version of that determination, I think they're hoping to publish that towards the end of next week, might help give patients a little bit more to go on in terms of reaching that decision. But it was a really difficult decision at my end, and I'm just trying to be as honest as I can in expressing the things that I was trying to weigh up and balance in making that decision about whether to proceed.
Charlie, thank you for your openness and your candour. And that's a word that's certainly pertinent here. I mean, we're going through a whole process around the duty of candour, particularly given the hyponatremia scandal, the Muckamore scandal, the organ retention scandal, and now we've got the neurology scandal, and it doesn't bode well in terms of openness and transparency. And I feel your frustration in terms of what is public interest and what is, within the public interest, and we don't know. So that's the bottom line. You have had the privilege of seeing that information, and the people most impacted by it haven't. So, I would just appreciate the fact that when the public inquiry concludes and when the Rqia investigation concludes, there may very well be a police investigation. None of us know. But it just feels so unjust that someone who is in a position of trust and great privilege has almost been allowed to remove himself from the register, and the trauma that people are still going through, they just feel that there's no one standing up or who've got their back. And these are life-changing events for them. And I just feel, and I'm sure you as well, I just feel that they've been just shafted, to be quite honest. And I feel that in terms of confidence going forward, there's a lack of it, and that's not a comfortable position. For me as an MLA on this scrutiny committee, I can't scrutinise. It's like trying to catch smoke in a bucket. Yep. With this whole process, there's very little there for us to scrutinise, and we're trying to take people at face value, but at the same time something doesn't feel right here, and if it doesn't feel right, it doesn't look right. In my experience, it isn't right. But listen, I'll leave it at that, and I want to thank you for your presence here today at the committee.
Okay, thank you, Carol. I'm going to Jerry then.
Thanks, Chair. Thanks for the presentation. My experience as a former patient of Dr. Watt, feel like they'd run out of avenue and space completely. They feel that doors are being slammed in their face repeatedly, and that the judicial review decision, in my view and many of their views, should be taken. And I'm quite struck by Charlie's statement that basically the JR would be lost before it's even been tested or tried. It's quite startling. I haven't seen the evidence that he's seen, obviously, but to me that seems quite startling indeed. There's also some concern that the NPTS decision itself is even lawful, and there's questions around that. And with respect, I think it's a bit of a cop-out. I'm hearing legalistic jargon for this not being challenged, and many people feel that there's an element of circling of the wagons of people in the medical profession. Many feel that way. They've been having doors closed in their faces repeatedly, and they feel that this is another example of that. And I think disgracefully it's fallen on the former patients' shoulders, who have gone through so much already, who are dealing with so much. The pain, the responsibility of challenging this is falling on our shoulders, and I think that's unacceptable. I think the GMC has a duty to proceed with this judicial review. So I'd just like to make those points. And my question would be, will the GMC publish the NPTS decision to accept erasure? And if not, why not?
Thank you. Look, I completely understand the perspective that you have on the judicial review. Had we had a right to appeal as we have on other decisions that the Medical Practitioner Tribunal make, we would have been able to proceed with the process because we disagreed with the decision they made. The problem is we don't, by law, have that right of appeal on a decision to grant voluntary erasure to a doctor, and I completely appreciate the frustration, particularly from patients, about what you described as legalistic jargon in terms of that judicial review. But the threshold for a judicial review is exceptionally high. In essence, you have to be able to demonstrate that the tribunal either acted illegally outside the remit of the law, that they acted irrationally in a way that was completely illogical, or in a way that was procedurally improper. And in order to be able to kind of address any one of those three pillars, you effectively have to be able to say that no tribunal acting reasonably within its powers could have reached the same decision as that tribunal did. And I have to take legal advice, and the legal advice was as definitive as it gets in terms of saying that there'd be no realistic prospect to succeed. And I do understand that perspective about saying, well, that there is still the prospect to proceed with that judicial review, even if you don't think you're going to win. But as I said earlier, it's one of those really difficult decisions, and I know people will disagree with me around it, but I felt that it would be misleading to patients to proceed with a process that I felt there was no prospect of succeeding whatsoever. In terms of your question about publication of the MPT decision, that is not a decision that I'm able to take. So it was the Medical Practitioner Tribunal that made the decision for the hearing to be held in private, and then the determination that they wrote that ran to 18 pages, which hasn't been published. The question is for them about what of that they may be prepared to publish. My understanding is that the tribunal, in response to some of the representations, both from the GMC and from patients, has agreed that they will be publishing a redacted version of that determination, and they're hoping to do so towards the end of next week. So I hope the committee will obviously, when you receive that, be able to ask some questions, probably directly of the Medical Practitioner Tribunal, but I also recognise the Chair's earlier comment to ask nonetheless for the full version of that determination, and I think obviously that's entirely for the committee to decide to press those points to the Medical Practitioner Tribunal service.
Yeah, just quickly, Chair. I mean, this is the biggest recall in NHS history, and you know, the right to appeal doesn't need to exist. You know, the JR decision can be taken. We've got community groups taking JRs in many cases here. Individuals taking JR, so many people feel that the GMC should proceed with that, and your legal advice, whilst others would take maybe a different legal opinion on that. And the concern about maybe the redacted version is that, you know, important information will obviously not be in it. So I would implore you to release that MPT decision or reasoning, because I understood that you had it, if I picked you up correctly.
Yeah, I mean, Anthony may want to comment, but we're not legally able to share that. It's not in our gift to be able to share that determination. That is a decision for the Medical Practitioner Tribunal. But Anthony, you may want to add if I've misrepresented that in any way.
No, and I think we completely take the point, and indeed we have pressed the MPTS to release their decision. I think the committee can ask them to do so. And then it's a matter for them. We would certainly rather it was released as a whole, because I think that would give you the complete picture. So I think we can press on our side, as Charlie says. We can't make them do it, and neither can we release it on our own. But we do support attempts to get the full decision released.
Okay, thank you.
Thank you, Jerry. And going into Alan Chambers. Go ahead, Alan, please.
Thank you, Mr. Chairman. And thank you to the speakers for attending this morning. They did say that this situation was quite rare of a doctor being allowed to deregister on his own volition, and also mentioned that it's about legislation. So I assume that all this is contained in parliamentary legislation. And I think we all accept that this was really an abuse of the legislation, and I've just asked the representatives if in fact the General Medical Council, in view of this, will be seeking to lobby Parliament to close this particular unacceptable loophole, and also fairly or unfairly, would you accept that this case has totally undermined public confidence in your ability to hold clinicians to account, certainly in this part of the United Kingdom? And thirdly, had Dr. Watt not deregistered, where would you have taken this case? What would be the time scale of your actions in it? And would your actions have been taken in the public domain? Thank you.
Thank you. I'll answer a couple of those points, but I might ask Anthony just to come in after I've spoken about some of the legislative questions that you asked. So you asked about public confidence. I completely recognise. I mean, this is one of the things that makes me very anxious. Is that this case and the decision that the Medical Practitioner Tribunal Service took has had a drastic effect on trust and confidence and regulation in Northern Ireland. I completely recognise that, and I genuinely feel very distressed on behalf of those patients who felt that they've been left unable to get answers about what happened in terms of the deficiencies of clinical performance and why their lives have been changed so terribly. I think we are a creature of statute, and we I want to make sure that we rebuild that trust and confidence. But I don't in any way take it as a trivial matter, and I do recognise that we have work to do, because this case will have led to that loss of confidence. If he hadn't been granted voluntary erasure, to your last question, the hearing itself was due to take place this month in November, and that hearing is one where we would have taken evidence to the Medical Practitioner Tribunal, and where I think patients would also have been able to engage with that process and observe that process. There would have been a question about whether Michael Watt himself would have been asked or able to provide evidence, and that would have been a question for the tribunal to determine, weighing whether or not there were health concerns that might have got in the way of that. And obviously those issues have been aired, I think, in public in relation to some of the challenges that the neurology inquiry faced in terms of witness evidence and their ability to ask Michael Watt to provide evidence to them. And my hope would have been that hearing process, my very clear expectation rather than hope, would have been that would have led to a process which would have led to Michael Watt's erasure from the register. That would have certainly been the very strong case that the GMC would have made in that process, and we would have gone into it with a great deal of confidence that we would have prevailed in getting that decision. But of course, because the hearing itself was simply around whether or not to grant voluntary erasure, we never got past that point in order to be able to bring that evidence, which is, I think, so harmful in terms of the public interest and the consequences in terms of the trust and confidence that you mentioned. Anthony, I might just come to you on the question about the kind of the legislation and how the kind of how that works in terms of the relationship between rules, Parliament, etc. So, Anthony, over to you.
So the member raises a very good question around voluntary erasure. It is something we grapple with because it is clearly seen by members of the public as a get out of jail free card. We do have a moment now, because we are going through some regulatory reform, to look again at how that operates. There will be clearly legitimate cases where a doctor can remove themselves, for example, when they're not facing any fitness to practice inquiries and or want to retire on health grounds, that they can remove themselves. But I think we can take the opportunity, I would say, to consider with others what would be appropriate in terms of voluntary erasure and what would clearly not be appropriate, and perhaps make that clearer in the public interest and in public confidence, because we completely accept the point. It is something that the public see as an easy route to avoid responsibility and accountability, and it's not something we like or agree with, but it's currently legislation. So we do have a moment now, because we are undergoing a period of regulatory reform, to take a look at the criteria and make sure we get that right in the public interest.
I think if you work hard at trying to close this loophole, I think it'll go a long way to restoring confidence that you do see this as a serious it is a get out of jail card, and you are going to do something about it. I think that if you don't take action on it, I think it will only add to the frustration and the feeling that really you've let people down. But I wish you well in your efforts to try and change that, and I understand your frustration and accept that. Thank you.
Thank
you, Alan. And going then to Paula. Go ahead, Paula, please.
Thank you, Chair, and thank you, panel, for your information this morning. Appreciate that. A lot of the questions I was going to ask have already been raised with you, so I'll focus in on the submission you made there in terms of taking action on concerns, and you referenced that there was 8,500 in 2020. I estimated about 75% of those were raised by the public and 25% by medical professionals. So I have two questions for you in relation to that. First of all, how has your experience in dealing with this issue with Dr. Watt influenced your response to the departmental's consultation on duty of candour? And secondly, you mentioned that in 2018 the Dr. Watt was referred to you by the Belfast Health and Social Care Trust. Did he come under your notice? Had he been referred to you before by any of those medical professionals? Thank you. That's the first question. Thank you.
Thank you. So perhaps if I take the GT of Canada question and perhaps Anthony can cover off the question about our engagement with Michael Watt. So yes, we did respond to the Department of Health consultation on GT Canada in August, and I'd be very happy to share that with the committee if you haven't got that already. And the first thing I'd want to say around GT Canada and obviously the conclusions that are coming out of the Justice O'Hara report is that firstly our thoughts and sympathies remain with the families who tragically lost children to hyponatremia in Northern Ireland. And I think one of the most important things coming out of that report is the importance of candour. Our view at the GMC is the most important element for driving more candour is around the organisational responsibilities for creating cultures and leadership that drive candour. And obviously, whilst we will work with the Department of Health on whatever conclusions are reached in relation to candour in Northern Ireland, we have expressed some anxieties about attaching criminal sanctions to the individual duty of candour. Not because we don't think it's important. I think there's particularly in Northern Ireland, I think it is of critical importance to improve candour within the system, but more that we're worried that creating criminal sanctions could drive more fear and blame and actually be counterproductive in driving candour. We know from we have many fitness to practice cases across the UK where there is an interplay between a clinician's individual responsibilities and where the criminal justice system gets involved. And we produce various reports over various years on this. But where there is that criminal element, we've seen that tending to drive more fear, more blame, more scapegoating of individuals. And my anxiety will be that will divert attention away from the things that I think are the most fundamental building blocks in candour, which is about that organisational responsibility. So that's our position on that. I know that there, and I respect the different views there are around that. It's a complicated subject, and whatever conclusions are ultimately reached, we at the GMC will play our role in ensuring that we implement those to the best of our ability and to mitigate the things that I've just described that I'm worried about. But Anthony, you might want to come back to the question about engagement with Michael Watt before 2018.
Thank you, Charlie, and thank you, Member. I think, and we have given this evidence to the neurological inquiry. Sorry, I've had a bit of an echo.
It's fine.
Yeah,
okay.
Just ask everyone. Just sorry, Anthony. Ask everyone just to go on mute for that feedback. Thank you.
Is that okay?
Yeah, try it now, Anthony, please.
Okay, so I think as Charlie said a bit earlier, we introduced... Sorry, I'm still getting loads of feedback.
It's not too bad, we can still understand you.
Yeah, it may be difficult for you, but it's clear enough here, Anthony, just to let you know that if you can try and work your way through.
Okay, I'll press on. So as Charlie said, back in 2013-14, we introduced an outreach service, which is a senior member of the GMC having a conversation with the responsible officer about emerging concerns and ongoing cases. Mr. Michael Watt was not discussed with our outreach person, and the concerns and the pattern only emerged in 2018. And once it did, as I've said, we took action immediately to investigate and refer the case to the tribunal.
It sort of broke up the company, but no, thank you for that. And I suppose we're all waiting to see what the inquiry panel actually produce in terms of their report, but I appreciate that update. My second question is in relation then to the again, your report talked about the overseeing doctors' education and training and setting educational standards, not just in undergrad but postgrad. I'm just wondering again how your experience in this huge public health scandal has influenced your work in relation to ensuring that the highest possible standards are met, especially in regard to neurology education. Thank you.
Thank you. It's a really good question, and our role in relation to education and training is to oversee and quality assure the postgraduate training environment, but we also work with medical students as well, and we've put a lot more emphasis over recent years on improving professionalism amongst doctors in Northern Ireland, including on the importance of speaking up and candour, which of course relates to the question you were asking me earlier. So we've provided dedicated professionalism days for all doctors in their second year of their foundation training in Northern Ireland. We've done that with NIMDTA. We've also created a compulsory professionalism module for all doctors who are early in their specialty training. So that's the period of training they have after they've been through the foundation programme. And we've run workshops for doctors in all of the 5 HSC trusts in Northern Ireland as well. One thing I am actually really pleased about in Northern Ireland is that unlike elsewhere in the UK, the Welcome to UK Practice induction training that we run for doctors who are new to practice in the UK has been mandated in Northern Ireland for doctors within 3 months of taking up post, and that's important because we rely enormously on doctors from overseas in terms of providing the medical workforce on whom we rely, and we do know that lots of doctors get into trouble, particularly around those issues around professionalism, not just speaking up, but also their ability to communicate, work in multidisciplinary teams, etc. And that induction training, we think, is a really good, effective, preventive measure that means that we can get the best out of those doctors. But I think there are issues, and we have our national training survey, which gives us data on what trainees are telling us, and to those questions around candour, in our 2018 National Training Survey, it was interesting that if you look across the UK, 6% of trainees use that survey to escalate a complaint, but not a single trainee in Northern Ireland did so. And the numbers of trainees in Northern Ireland that said that they feared adverse consequences for reporting bullying was higher than elsewhere. So I think there are issues still that we want to address. Our data gives us some really good insight in terms of the things that we need to be doing, and part of what we're determined to do at the GMC is work with the other system players, so NIMDTA, Rqia, obviously the clinical governance engagement that I described earlier with trusts. All of those things are really important, because ultimately what we want to do is to support doctors to provide the care that patients need and avoid the harms arising in the first place.
Okay, thank you very much. Thank you.
Thank you, Paula. And going then to Rqia. Go ahead, Rqia, please.
Thanks very much, Chair, and thanks to Charlie and Anthony. I just wanted to touch on, to come back to some of the points that Alan had raised, and Anthony, I know you had touched on this in some of your answers. It was around this issue around, I suppose, some of the learning from this whole process and experience. So I know that it's probably too late at this stage. If the JR can't be taken, it's too late at this stage for the patients and the families that have been impacted by this scandal. But I think then if there's ever a motivation to review some of these processes, to review some of the criteria, it needs to be done now. Because I don't think it's right that we end up in this situation again, and that any family or patient ends up in this situation again. And I know that you have spoke about your own disappointment and frustration, and it's good to hear that feedback. But and I do think it's significant that it is the first time in history that you were even considering that JR. So with all of that in mind, I'm just wondering, what role specifically can the GMC play in reviewing some of this criteria, even around what those exceptional circumstances are? And is that something, that process, that regulatory reform, Anthony, that you had spoke about, is that a process? How soon can that process get underway? And it would be good for the committee, if the committee's in agreement, it would be good to be kept up to speed with, any progress there, because I think it's really, really important that it takes place now, so we don't come back to this situation in the future.
Anthony, did you want to pick that up? And I might make a couple of broader points after that on lessons learned, if I may.
Okay,
but Anthony.
Yeah, happy to. I completely take the point about the learning and making sure we do it. So we are currently working with Department of Health England on the reforms, various changes to our legislation, and we can pick this up. And I'm sure we would be. I mean, they will obviously be consulting with the Northern Ireland Assembly at various points, but we're more than happy to keep you informed, and I'm sure my colleagues who lead on this will be able to bring you up to speed with where we are. We will absolutely take the learning. We always try and do that, and we're at one with you to make sure that we do what we can to prevent this happening again, absolutely. And if there's stuff we can do in the legislation or practice, then we will be doing that. So I can reassure you that we will be thinking about this. The other point is obviously the neurological inquiry will report in terms of not legislative changes, but other changes perhaps and things that can be done. And we will absolutely wish to play our part in that as well. So I hope I can give you that reassurance that as part of the regulatory reform, we will be looking at how we better protect patients within the framework we will get, and there will be public consultation and engagement on that as well as we go along. So I think we can give you that assurance, and wherever else there is learning, the Rqia inquiry or the investigation inquiry, we will actually take that as well and do our bit.
And just to add, if I may, I mean, obviously we'd be very happy to keep the committee engaged around that process in whatever way you find most helpful in terms of those specifics, in terms of regulatory reform and how these bits of our process may be things that we would be able to change when we've got more freedom to do so, when the government's legislated to give us that autonomy. The broader point is I think, and this comes back to some of the earlier questions, in terms of the kind of the deep distress and frustration for patients, I think it is absolutely critical that there are lessons that come out of the neurology inquiry, and certainly we've given evidence suggesting some of the lessons that we think might be applied. I think there are issues in there around improving and strengthening clinical governance. I was asked earlier about, I think from the chair, around appraisal and revalidation. I think there is more that we with trusts can do to spot doctors not engaging in that appraisal process, and I think there may be more support that we and others should be providing for those most senior doctors in terms of how they oversee clinical governance environments. So I think and hope that there will be a number of lessons that could be learnt, and certainly the GMC's ready to play its role in taking those forward.
Thank you. And maybe just finally, I'm conscious that you said earlier in your presentation that obviously your interest in this case remains high, that your engagement with the patients is going to continue, and also that you've offered to meet with the families. And the families, I'm sure a lot of them will be watching into today's meeting. So is there a message that you can give the families today in sort of what active role that you can play to try and support or reassure them in the time ahead?
So I think the first thing I can say to patients is I'm very sorry that we've got to the position we have in terms of the hearing with Michael Watt, and I recognise that the patients will feel both angry and disappointed with the decision that I've made not to go ahead with the judicial review. We want to offer those meetings because I want to be very open with families about why we've done that. I've sought to explain some of that today. Obviously, we're constrained in the precise detail of that because of the private nature of the hearings and the determination from the NPTS. But I hope that when the Medical Practitioner Tribunal publish, albeit a redacted version of that, then there'll be more for us to be able to engage with patients around. But I do also just want to reinforce that even though we're not able to take Michael Watt's case to that full public hearing, I still do want to make sure that we play our role in learning lessons. I know that won't that won't be sufficient for many patients in terms of their thirst for understanding and justice and accountability in relation to the harm that they've suffered. But I think there are lessons to be learned both for the GMC and the wider system, and I'm absolutely determined that we follow that through.
Thank you.
Thank you, Rqia. And going then to Deborah. Deborah Erskine. Go ahead, Deborah, please. We may have temporarily...
I can't hear Deborah.
Can you hear me okay now?
Yes.
Yes, we're hearing
Sorry.
you now, Deborah. Yeah, go ahead.
I just want to thank Charlie and Anthony for coming to the committee today. My questions really are, first of all, can the GMC clarify if the MPTS is ultimately funded by doctors themselves, and if so, is there a potential conflict of interest there?
So the MPTS is funded by the GMC, so it's funded by me, and the GMC in turn is funded by the registration fees it receives from doctors. So ultimately, the funding for the GMC and the Medical Practitioner Tribunal Service is through the license fees that doctors pay in order to be able to practice medicine. But I don't think there is a conflict, because there is nothing that binds the Medical Practitioner Tribunal or the GMC to essentially consult with the profession it regulates about how that happens. So I'm satisfied that there is no conflict in that sense. Obviously, that doesn't change the frustration and disappointment that we all feel in terms of the decision that they reached.
Okay, thank you. And could you maybe explain in detail why the GMC can't appeal, as the MPTS website says that you can?
This is probably one where I hand over to Anthony, who's across all of that legal detail.
Thank you. So the reason we can't appeal is that the powers to appeal are set out in legislation, and the decision to grant voluntary erasure is not one of the things that we're allowed to appeal. So that's why we went down the JR route. So we as a creature of statute, a creation of statute, can only do what we're given powers to do. And one of the things they didn't give us powers to do was to appeal voluntary erasure decisions. So that's why we explored the judicial review route, because we can't, as Charlie said, had we been able to appeal, then we most likely would have appealed.
Okay, thank you.
Okay, thank you, Deborah. And Colin.
Thank you very much, Chair, and thank you to Charlie and Anthony for their presentation. I just want to begin by acknowledging the pain and suffering that people have gone through as part of this process, because this is one of the first opportunities I've had to have a discussion about this process with being a new member to the committee. And unfortunately, the GMC is being viewed in this as unhelpful at best. And that is a very difficult position for the GMC to be in, and one that they shouldn't be in. I think that the decision not to pursue the judicial review due to a potential failure, rather than actually using the judicial review as a process to shine a light on what happened, I think that decision is lamentable. And I was just wondering if you might be able to detail, just maybe pursuant to what Deborah had asked, in terms of that panel, who actually sits on the panel and what would their backgrounds be?
Thank you. I'd probably start with Anthony, just in terms of the panel and constitution, then perhaps come back to the JR decision itself. But Anthony, do you want to kick off with the panel constitution?
Yes, sure. And again, as I hope you recognise, we share those frustrations and completely take the point about the damage done. The tribunal members are usually a lay member, any work of life, a doctor who's in practice, and a legal member or legally qualified chair, supported by a legal advisor. So you usually have a panel of three, where you have a doctor, a lay member, and a chair who could be legally qualified. So that's the normal constitution.
And just on the judicial review comment, I mean, I do understand the point you make about that the GMC is being seen as unhelpful at best, and the disappointment with the decision not to proceed with the judicial review. I'm at risk of repeating some of the comments I've made earlier, but you know, as a creature of statute, we have to take legal advice on these questions. As we sought to explain, if we had an appeal right like we have on other medical practitioner tribunal decisions, I would have been very surprised if we hadn't taken that route and sought to appeal, because we would have been able to present the arguments about why we disagreed with the MPT in terms of the public interest outweighing the private interest. The problem we have is that the judicial review process has completely different thresholds. And when I'm confronted with legal advice that says we literally have no chance of succeeding with that process, I reluctantly concluded that it would be misleading to proceed with the process, because I think it would be very hard to get across to those patients who've been so dreadfully affected that we're starting a process which would lead to some sort of justice or accountability, when we were absolutely clear in our own mind that that wasn't going to be where it would land. I would feel that I was dreadfully misleading patients in terms of where that process would go. I recognise that there will be a number of voices, and I respect that view completely, that will say, notwithstanding all of that, you should have made that decision to proceed because that would have given patients some hope. But I think the hope would have been so faint that it would have created some false expectations, and I think that wouldn't have been fair to patients. That's the view I reached, but I do understand people will take different views on that.
Can I just ask about that? The appointment of that MPTS panel. Who actually appoints those lay members, doctors and legal chair and advisors?
So they're appointed through an open process, so an open recruitment process. So we advertise nationally, and then the MPTS, usually Dame Caroline and her officers, will hold interviews and go through a normal recruitment process, and then people will be appointed to a list and called off the list for various panels. So it's not always the same panel. You pull 3 people together for a case.
I think it's the impression that you're paid for by doctors, you fund the scheme, you self-appoint the people that go on it, and in this instance it's decided that for one of its own it doesn't want to pursue any further action. It sounds more like the Tory party yesterday involved with MP standards than it does anything else, but I think you'll have to just stand accused of that, and hopefully that you'll make amends for the future for that process with the learning from this. But thank you very much. Thank you, Chair.
Okay, thank you, Colin. Okay, so listen, there's a couple of quick questions there, and I'm very conscious of time at this stage, so I'll just fire the questions. They've occurred sort of as a result of the evidence that you have given there this morning, Charlie and Anthony, and then I'll go to panel. I'll go back to members then for a further discussion. But a couple of quick ones. So you'd mentioned that on 2 occasions the voluntary erasure was declined, and on the 3rd occasion it was accepted. What changed the 3rd time that, in your opinion, that allowed that to be accepted the 3rd time of asking?
Anthony, do you want to pick that one up?
Yeah, it's a good question, Chair, but I'm slightly restricted in what I can say about what changed, because to do so would reveal some of the evidence that was given at the tribunal. I think it is, as Charlie said earlier, well known that Michael Watt is unwell, and so you might surmise that that was part of what was considered. But I can't really give more than that, other than to say we at the GMC considered the applications twice and refused it. But obviously, the 3rd time, which was some time later, the tribunal took a different view.
And Chair, if I may just add briefly, one important distinction is that the previous 2 applications were made directly to case examiners. So those are people who actually work within Anthony's directorate within the GMC. It didn't go to the Medical Practitioner Tribunal. So those were decisions that were made by the GMC without going to the Medical Practitioner Tribunal. The 3rd occasion, because the hearing was listed, the application by Michael Watt's representatives was to the Medical Practitioner Tribunal. So the difference in terms of process was that was then a hearing by the tribunal with the panel that Anthony described earlier, and therefore the GMC was one party arguing its case in that tribunal. And obviously we can't go into the detail, we're not permitted to go into the detail of the differences in argument that were presented at that time, but it meant that the decision making was of a slightly different nature than it had been previously. Okay,
thank you. The second question was around the revalidation process, and you had referenced in your evidence there that that is taking place every 5 years. So Dr. Michael Watt had revalidated in 2013. His next revalidation was therefore going to be in 2018. And given that you've identified that may have had an influence or an impact on the appraisals being carried out, Do you agree that a lot of harm and damage, and this case demonstrates how much harm and damage can be caused to people in a 5-year period, that potentially needs reviewed? Is that something that you're looking at?
So we're always constantly reviewing how we can undertake our role in a way that is most effective at underpinning clinical governance processes. I would argue it is the annual appraisal that is the most important piece of information for a senior medical director in terms of being able to satisfy themselves that doctors are up to date and fit to practice. The revalidation process sits above that, and there is always a debate about should that be on a 5-yearly cycle, a 3-yearly cycle, a 7-yearly cycle. It's something we will always review, but I wouldn't want to suggest that revalidation is something it's not. The most important element is what happens in terms of that annual appraisal process, and I think the fact that we now have the outreach capacity, that means that every single senior medical director has a relationship with a senior GMC individual, is, I think, one of the most important mechanisms we now have to both support and understand the strength of clinical governance arrangements locally.
Yeah, and I think the relevance there is that I think the implication was, and there would be strong indications at this point, at the very least, that the lack of annual appraisal in this may have been an exacerbating factor. And I think you were saying that revalidation put the focus on the appraisal, and therefore the two are interconnected. More generally then, there was discussion there around regulatory reform, and I think we're very conscious as a committee here that within a lot of the scandals that we are currently dealing with within health, governance has proven to be a factor in, I believe, each and every one of them. So in light of that, and maybe this is in light of the time, maybe this could be forwarded to the committee, but what proposals are being discussed at the minute in terms of regulatory reform, which will help provide that rigour and that confidence to people out there that the governance system is fit for purpose? So can you briefly outline, or could you send us on further information in regards to that?
So I'll say two brief things, but I'm very happy, Chair, to write with more chapter and verse to the committee if that's helpful. So the first piece is that the UK government that kind of underpins all of our legislation has made a commitment to give us much more autonomy in the way in which we set the rules around things like fitness to practice, education and training, registration and revalidation. And that's going to take a couple of years, but that's going to give us a lot more freedoms, and we will be consulting when the government has made that legislative change about how we want to operationalise that, but we can write with more detail. The second point is that there are some other things that we seek to achieve in terms of strengthened clinical governance. So I mentioned earlier some of the things around senior doctors, the support for responsible officers, who are the people who have that overall accountability within trusts for overseeing doctors, and I'd be very happy to write setting out some of the changes we would like to see legislated for in that context as well.
Okay, listen, thank you, and I want to thank you both for attending and for addressing committee members' questions, and we will have a further discussion now. But for now, I want to wish you all the best and take care, but we can let you go now and we can continue on with our considerations. So Charlie and Anthony, good luck and thank you. Okay.
Thank you very much. Thank you.
Sorry, just before you do go, sorry, Charlie, before you do go, I did want to actually make the point, and I have to say this, and this is personal around that, my personal view around what has been discussed, the duty of candour, and I think this case actually highlights very worrying elements around individual duty of candour and around the ability or the potential for individuals to not cooperate with inquiries. I think that is regrettable, and I think it's something that needs to be considered very carefully by all of us who are engaged in working in the provision of health and social care. I think it's and I'm very conscious this morning, and I want to send the solidarity of this committee out to all those family members and patients of the neurology scandal, but also of hyponatremia and other scandals which are interlinked and share many of the same characteristics, and repeatedly we seem to see these things arising. So I think it's important work in that sense, and I think that's something that the GMC should bear in mind, as well as everyone else. But again, thank you for attending today. Thank you.
Our pleasure. Thank you.
Okay. Thank you. Members, I will go to members then for a discussion, then a brief discussion if we can, because we're already over time. A brief discussion if we can in terms of other steps that we might consider taking. I'll go to Pam first, and then I'll go to Carol, and if members want to indicate then if there's anything additional. So Pam, go ahead.
Thank you, Chair, and I'll be brief here. I think it would be really good, given that health is obviously an evolved matter here, and the GMC and the MPTS are ultimately UK Parliament. I want to suggest, or in fact propose, that this committee write to the Westminster Health Committee to put pressure on the GMC and the MPTS to explain the lack of transparency for patients and the lack of accountability for Dr. Watt.
Okay. Members content? Yeah, members content. Carol?
Yeah, I completely agree with Pam on that, but given the fact that we have an office of the GMC here, and the fact that the MPTS is a statutory committee of the GMC, I think it's completely appropriate that the MPTS are asked to come in front of the committee if it's possible. And just to say, Chair, that we don't know how sick Michael Watt is. We've just had to rely on other people's evidence. But what we do know is, and we all know, that the patients from Michael Watt are really ill and with life-limiting and life-transforming diagnoses, and even all that mistreatment. So I just want to put that in the record as well, because I think it's really important. We don't know Michael Watt's condition because we haven't been able to scrutinise any of the evidence. In fact, we haven't seen it.
Yeah. Okay, so a proposal that we explore getting the MPTS to provide evidence to committee. Are members content with that proposal? Yeah, content. Okay, members, I don't see any other indications, so I'm going to take a short comfort break there, just 5 minutes. If we can come back at 11 o'clock and we'll resume the second briefing. Thank you, everyone, and we're now resuming then our meeting. So we're moving then to our second substantive briefing. Item 6 there on your agenda is a briefing from the Department of Health on neurology, and I think it's important just to note that we are putting a particular focus this morning on neurology, and that's reflective of the committee's concern for the scale of this issue, the impact it has had on so many of our people out there, and I think it's useful to put a particular focus, as committee have asked, on this particular issue. I refer members to departmental paper on the regional review of neurology services and neurology recall, which is at tab 6.1 of the pack. Department officials are here to brief the committee today on the work of the department on this matter. So I'd now like to welcome, and just to check the sound, with first of all Mr. Peter Jacobson, who is Director of Surge Planning and Health Service Transformation. Can you hear us there okay, Peter? We're not hearing you, Peter, and you don't appear to be on mute, but we weren't hearing you there. No, we're still not hearing you, Peter. I'll check in with the other two and give you a wee minute there, and I'll come back to you. Mr. Robbie Davis, who is Director of General Healthcare Policy. Robbie, can you hear us okay? Okay, we're not hearing you either, Robbie. So I'm not sure if there's a wee system issue there, but I will try again. And we are also joined by Miss Anne-Marie Bovill, who is General Healthcare Policy. Anne-Marie, are you able to hear us? And more importantly, this time, I think, are we able to hear you?
Yes, Chair, I can hear you. Can you hear me okay?
Yes, we're hearing you fine. So, gentlemen, if you could please do whatever Anne-Marie, and follow her example there, and do whatever Anne-Marie has done correctly. If you could please, and I'll check again then with Peter. No, still not hearing Peter. And still, Robbie, can I check with your sound?
Are you able to hear me now, Chair?
Yeah, I'm hearing you, Robbie. So, given that Peter is having difficulty there, is it possible for either one of you to lead on the briefing and to give Peter some additional time? Can we go that way? Or do we need to hear from Peter?
Certainly, Chair. I'm happy to make a start and then hand over to Peter once he gets his system in order, which hopefully he'll be able to do.
Okay, well listen, thank you. You're all very welcome, and appreciate your coming to committee today. And so go ahead then, Robbie, and we'll see how things work out. But if you want to kick off there, please do.
Okay, firstly, I would like to thank you, Chair, for the opportunity today to update the committee on the neurology patient recall. I understand you will have received the briefing paper already, setting out the progress to date relating to Cohort 1, Cohort 2 and Cohort 3 patient recalls. By way of context, it is important to note that the purpose of the neurology recall was to see and assess individuals who had been under the care of Dr. Watt to ensure they were receiving the care and treatment they required. The first recall of patients of Dr. Michael Watt, Cohort 1, was initiated in May 2018 in response to emerging concerns at the standard of treatment being provided. The primary focus of the recall was on ensuring that each patient was receiving the correct form of treatment. The consultants reviewing recalled patients considered 3 key questions in line with a recommendation from the Royal College of Physicians. These related to whether the diagnosis was secure, if a proper management plan was in place, and if prescribing was accurate. The responses by the reviewing consultants to the 3 RCP questions in respect of Cohort 1 patients was summarised in the Cohort 1 Outcomes Report, which was published in December 2019. In October 2018, a second cohort of the neurology recall commenced. This included past patients of Dr. Watt who had been referred back to the neurology service for review by their GP. This group was known as Cohort 2A. In addition to this, past patients of Dr. Watt in high-risk groups who had been seen by him between 2012 and 2017 but discharged back to the care of their GP were also invited for recall. This group was known as Cohort 2B. Cohort 2B was focused on patients who had been prescribed anti-epileptic drugs, immunosuppressants and disease-modifying therapies used to treat epilepsy and MS. The Cohort 2 Outcomes Report was published on the 20th of April 2021 and includes the overall outcomes of the review. The outcomes of the Cohort 2 recall found that a significantly higher proportion of patients in Cohorts 2A and 2B had a secure diagnosis than was the case for Cohort 1, at 76% versus 68% respectively. However, there remained approximately 1/5 of patients with an insecure diagnosis. The findings of the other RCP questions were broadly similar for Cohort 1 as for Cohort 2. In the context that a significant proportion of the Cohort 2 patients did have an insecure diagnosis, the advice from the reviewing consultants was that it would be appropriate to also review an additional cohort of Dr. Watt's patients. This was known as Cohort 3. The Cohort 3 recall was announced on the 20th of April 2021. Cohort 3 included patients who were discharged between 1996 and 2012, who met certain criteria, alongside a number of patients that had not been reviewed up to this point, but now fell within the scope of the recall due to factors including the widening of parameters such as age range. 276 patients required a recall consultation. This included patients who had continuing prescription of higher risk medication, for example, epilepsy medication that had been prescribed by Dr. Watt and who had not subsequently been seen by another consultant neurologist. Another 495 patients required further GP information to ascertain if there was a requirement for further recall consultation. This included those who had been identified as currently being prescribed low-risk medication only. Around 80 to 85% of the Cohort 3 patients were from the Belfast Trust, with the remainder of patients from the Ulster Independent Clinic and Hillsborough Private Clinic. The Belfast Trust issued letters to patients falling under the Cohort 3 recall on the week commencing 19th of April 2021. A patient helpline was made available from 9 a.m. to 9 p.m. in the 7 days of the first week and was subsequently made available from 9 a.m. to 5 p.m. from Monday to Friday in following weeks. A letter of apology was also issued by the Belfast Trust to the patients who were included within this recall. This included details of the support made available. The Cohort 3 recall process has now been completed and the development of an outcomes report is currently underway. In addition to the 3 cohorts already covered, a further number of patients of Dr. Watt were reviewed as part of the epidural blood patch review. This included patients who had not been part of previous recalls because they had since been reviewed by other neurologists. Initial findings from the Trust indicate that 46 out of 66 patients had care that was unsatisfactory and fell below standard we would expect. Additionally, the review established that for 45 patients, there was no clinical evidence to support that a blood patch procedure was required. The Belfast Trust commissioned the Royal College of Physicians to validate a random selection of the 66 patients whose case notes had been reviewed, having had a blood patch procedure under the care of Dr. Watt. An interim report by the Royal College of Physicians indicated that their findings are generally consistent with those of the Trust. The RCP convened a panel of specialist clinical reviewers to provide independent opinion regarding the quality assurance of the Trust review, looking at a third of these 66 cases. A final copy of the quality assurance report and clinical record review has been shared with the department. The report indicates that there was a high level of concordance between the judgments reached by the RCP review team on the 22 cases and the judgments reached by the Trust. The overriding conclusion from the review is that the desktop review of cases undertaken within the Trust was robust and effective. The report makes 12 recommendations to the Trust. As some of the recommendations have the potential to identify patients, the report cannot be made public. The Trust have accepted all the recommendations and are taking steps to implement them in the timescales set. The Trust has previously written to the patients whose cases were selected as part of the review by the RCP, and the Trust subsequently wrote to the patients and advised of the RCP review outcomes specific to their own individual case. Some patients have made contact via the Neurology advice line to have the details of their case further expanded on. The complete written detail regarding their care mentioned within the report will be shared with the individual patients upon request. The Trust continues to support those patients affected through the Neurology advice line. Chair, I hope you find this overview of the Neurology recall helpful. If you are content, it may also be helpful if I provide the committee a brief outline of the position of the other reviews which relate to the Neurology recall.
Yes, I think that would be useful, Robbie. Yeah, please do.
Thank you. There are 8 different reviews linked to the recall of neurology patients by the Belfast Trust, some of which I would highlight are independent of the department. 4 out of the 8 reviews were initiated by the Permanent Secretary of the Department of Health. These include 3 Rqia reviews and the establishment of the inquiry. The first I have
Robbie,
already...
sorry, we just lost you there for a second just at the very end of your remarks there. Could you just repeat the last part?
Apologies. So there are 8 different reviews linked to the recall, 4 of which were initiated by the Permanent Secretary of the Department, and 3 of those were Rqia reviews, and the 4th was the establishment of the Independent Neurology Inquiry. The first, I've already given you some detail on the recall of neurology patients, which was carried out by the Belfast Trust. And
we've lost you. We've lost you. We're losing you. We're losing you intermittently.
Secondly,
there.
The review.
Robbie, we're losing you intermittently. I'm not sure what's happening there, but we lost a bit of. We got all that about the Rqia, but we then lost the subsequent bit. And the independent neurology inquiry.
Apologies, Chair. Apologies, I've camera to see if that helps. The sound has. Are you able to hear me now?
Yes, I think. Although you at the start, when you started speaking there, it was breaking up, but I think towards the end it had improved. So give it another try.
Okay, third time lucky, I hope. The first of the 8 reviews spoken on the recall of neurology patients, which was carried out by the Belfast Trust, overseen by the PHA and the HSC board. Secondly, the Rqia review of the governance of our which focused on neurology services. This report was published in February 2020. In response, the HSC board and the PHA have been commissioned to work with all trusts to develop an action plan to progress the recommendations of this report. The department expects an update on this work in the near future. Thirdly, the Rqia deceased patients review. The current phase of this involves the records of 45 former patients' records. It includes the records of those deceased patients whose family members have approached the Rqia with concerns about their care and
Okay, we've lost there again, Robbie. What I'm going to do, Robbie, I'm going to check with Peter and Anne-Marie if
the
they want to
records
make
of
any...
patients who were in Clost's Cohort recall, but on
Robbie, and I think you're having difficulty hearing us. Robbie, I'm going to pause you there. I'm going to pause you there and I'll come back to you and see can we get your sound sorted out. I'm going to check firstly with Anne-Marie and then I'll go back to Peter. Anne-Marie, are you making remarks, opening remarks, or will I check with Peter?
Chair, if it would help, I can continue on with the remainder of Robbie's outline and take over from that. And Peter is due to give an update on the Neurology Services Review. So if it makes sense, I can continue on for Robbie.
Yep, perfect, Anne-Marie, thank you.
Okay, I think Robbie had started to outline the second review, which was the Rqia review of the governance of outpatient services in the Belfast Trust. So I'll just recap on that in case members and the chair didn't hear that. It focused on the neurology services, and this report was published in February 2020. In response, the board and the PHA have commissioned to work with all the trusts to develop an action plan to progress the recommendations, and the department expects an update on this work in the near future. Thirdly, the Rqia deceased patients review. Members may already be aware that the current phase 2 is currently in progress and involves the records of 45 former patient records. It includes the records of those deceased patients whose family members have approached the Rqia with concerns about their care. That's a total of 29 cases. And the records of patients who were included in the Belfast Trust Cohort 1 neurology recall, but unfortunately died before either attending or completing their reassessment, and that involves 16 cases. This phase is expected to be completed by April 2022, and a decision on future phases of the review will be made following the completion of phase 2 of the review. Fourthly, the Rqia review of the corporate and clinical governance of health services delivered in the independent sector. This report was published in June 2021. It makes 20 recommendations to improve governance arrangements in the independent sector, and the department is currently considering the recommendations and developing an action plan to respond to address those recommendations which have been accepted. Fifthly, the independent neurology inquiry. The inquiry focuses on governance in accordance with its terms of reference and is independent from the department. The inquiry isn't responsible for making decisions in relation to the clinical practice of Dr. Watt, and I understand the committee has received a separate written briefing by way of update from the inquiry directly on that. The sixth review was a Belfast Trust investigation in relation to the concerns about Dr. Watt that were raised by the Royal College of Physicians report. This investigation was conducted within the contractual and departmental framework of maintaining high professional standards in the modern HPSS. And I understand that this investigation concluded when Dr. Watt left employment of the Belfast Trust. The seventh investigation was a GMC investigation into the clinical practice of Dr. Watt, and I understand that GMC attended before the session this morning. The chair and members will be aware that the GMC is independent from the department. And finally, it could be considered an eighth review, which is not directly linked to the neurology recall, but it's the Neurology Services Review, which our colleague Peter Jacobson was attending to present on today. So hopefully that provides the chair and members with an overview of other related work streams.
Okay, thank you. And I will then check with yourself, Peter. Do you have sound going there? Are you just check? Can we hear you?
I hope you can. Can you hear me?
Yep, we're hearing you now, Peter. So if you want to go ahead then with your briefing, thank you.
Excellent. That's a relief, Chair. I was getting worried I wouldn't be able to hear me at all. Okay, well thank you, Chair, for the opportunity to update the committee on the review of neurology services. You should have received a briefing paper setting out the context for both the review and the recall. So the review was established in December 18. An interim report was published in October 2019, and work carried out until March 2020, when the review unfortunately had to be paused due to the pandemic. However, the review team reconvened in June this year, and we're hoping to make good progress in the coming months. So neurological conditions are common and varied. In Northern Ireland, we estimate there are just under 15,000 people with a diagnosis of epilepsy, 5,000 people who have MS, 4,000 people with Parkinson's, and 1,000 people with inherited or acquired neuromuscular disease. Neurological conditions account for around 10% of primary care consultations and 10% of emergency admissions. So the pressure on our neurology service is very clear. The committee will be aware of the pressure in primary care, and particularly in our emergency departments. But the pressure in terms of neurology is perhaps best illustrated by the gap between capacity and demand for new neurology outpatient appointments. We estimate this gap to be in the region of 6,500 per year. We also know that we simply do not have enough neurologists in Northern Ireland. Currently, we have 23, and we need to grow this to at least 40. Chair, I'm getting a bit of feedback, but I hope you can still hear me okay.
Yes, it's not great sound, but we're able to follow. But if you just take it slow as possible, we are following, Peter.
Okay, I'll try and slow down and try and speak up as much as I can. So we are looking at how we can grow the workforce, but we recognise that it will take some time to do so. For example, it takes 10 years to qualify as a consultant after students have secured a medical degree, and we clearly need to do more on this. We are also considering how patients are best supported, who provides that support, and whether that is best delivered in secondary care, primary care, or in the community. And the aim is to maximise our resources and improve patient outcomes. So the briefing paper provides a summary of the review work streams. These are considering potential reforms which could improve services. So the emerging discussions include an advice and guidance service to GPs. This would mean that more people with conditions such as headache can receive timely support from the GP. This model already operates successfully in the Southern Trust. In addition, experience from elsewhere suggests that advice and guidance improves overall access to outpatient services. We also consider an effective ward liaison service, whereby patients admitted to hospital with a neurological condition are assessed by a neurologist. This has been shown to result in a more accurate diagnosis and shorter length of stay. Furthermore, we are looking at a career pathway and training for neurology nurses. This is to realise the full potential of the nursing role. We are also deliberating how best to provide support in the community, and this includes how best to coordinate care for patients. And finally, we are considering development of a specific neurology pathway, and this will help to clarify the services that our citizens expect. So, Chair, it's important to acknowledge that our neurology workforce faces severe pressures and is chronically understaffed. Our clinicians and healthcare workers are striving to deliver the best possible service in what is a very difficult environment. As a clinically led review, the pace at which we can make progress is entirely dependent on the capacity of review members. And I think it's fair to say that despite the willingness and personal commitment of all review members, we are facing some challenges in this regard. So to try and address this, a piece of work is now underway to identify if more can be done to support review members. I don't need to rehearse the challenging context we find ourselves in, with very possibly the most difficult window ahead for the HSE system. And it's in this context that we seek to progress the review. It's therefore unlikely that it will conclude until late spring of next year. But as I say, this is all contingent on the review members' capacity this winter. So as the recommendations from the work streams emerge,
we intend to produce a final report. Depending on the recommendations, we will consider whether to conduct a full public consultation. As a final product, we intend to produce an implementation and investment plan. So regardless of whether a full public consultation is taken forward or not, we are keen to engage, continue to engage with key stakeholders, and of course including this committee. So I will finish there, Chair. I'm happy to take any questions.
Okay, thank you all, and thank you for that information. And I have to say, and this is not a criticism as such, because I know you have come to the committee to impart information, but in a sense, it's very dry, and it's very easy, I suppose, to forget that at the end of all these technical terms of cohorts and the various and multi-complex strands that are involved here, that behind every one of them are individual people who are struggling with the impact, struggling with the fallout of it, struggling to try to recover and struggling to try to engage. And I think we do need to, and I know everyone here does, absolutely keep those people at the centre of all our considerations. But with that in mind, what is being done currently to support the patients that have been impacted by this, and indeed their families? And I don't simply mean in terms of their physical or neurophysiological health, and that's hugely important, nor indeed even, which is also important, their psychological and counselling support, but how are they being supported to engage robustly to get the answers and the accountability and the transparency within these many layered inquiries? And it's hard, I think, even for us to follow the various strands at times. So how are people being engaged, being supported to engage with that concept of equality of arms with a massive system here that has caused them harm? So can you give me some idea of how currently you're engaging with patients and families to support them? Peter or whoever in the panel.
That's probably more for Anne-Marie and Robbie, that particular bit, but I mean, I can say how we engage with patients as part of the review itself. Yeah, it's not really support for the patients in that sense, but it's more to give them a say in the future services. So we have set up a neurology user platform in conjunction with the PCC, and that is to serve both the neurology recall and the review itself. So that will mean that that those service users and patients that are affected by the recall will also have a say in the future of the neurology service. So from the perspective, from my perspective, the perspective of the review, that's how we plan to engage with those patients, Chair.
Okay, and maybe Anne-Marie, I'll check if it's yourself. I don't see Robbie on screen. But supports for patients and families, Anne-Marie, where's that at? We're not hearing you there, Anne-Marie. Sorry, I just check. Are you still on mute? No, we're not hearing you there, Anne-Marie.
Hello?
Yeah, now we're getting you. Go ahead.
Hello, sorry about that. I'm aware that Robbie has, I think, tried to dial in instead because of IT issues, Chair, so hopefully he will be able to join and join the discussion on this. But yes, I'm happy to pick up the question in relation to patient and family engagement from the neurology recall and the neurology workstreams perspective. And the department is engaged and will continue to engage with patients and families, the health committee and others as appropriate. We have arrangements already in place through the patient and client council to ensure the effective communication with patients and families. And we appreciate the distress and the anxiety that these matters have caused in relation to the patients and families involved and affected by the recall. So we engage with the patient and client council in relation to, and we have good established arrangements in place for that to take place in order to address issues and matters under consideration and, following the outcome, for example, of an announcement. For any patient who remains anxious or worried, the advice would be to contact the Neurology Advice Line, the helpline, where there are it's manned by the staff, and advice and support is available there also. And it is, I suppose, important to highlight that these are highly complex matters that have been more difficult and time-consuming than expected, and the department appreciates the frustration felt by the families and patients involved. And the impact that the complexities may have had on the impact of delivering the work streams. Members and Chair will be aware also that the Minister has previously met with patients and families, and the Department remains committed to working with the PCC to make sure that that constructive engagement continues, to allow issues to be aired, to allow voices to be heard, and also to look for ways to further enhance that engagement that's already there.
Okay, thank you. And I am also conscious, as one of you pointed out, the fact that we just have had a session with the GMC where yet another avenue of redress for families has been cut off, and it creates an overall impression of a monolith, of a system that is talking about the issues, but talking to itself and not sometimes talking to families and keeping them not only involved in terms of informing, but actively involved in how the process has moved forward. So I think that's something that needs to be continue to be kept under focus. The other issue then, kind of related to that in a way, but maybe separate, is at the outset of all this, and I'm conscious of going right back to the briefings that were at the very start when this started to break. It was made clear that patients impacted by this would be prioritised in terms of having the reviews and having the scans and the further assessments that were needed to identify where there was a misdiagnosis and to then put them back onto the correct treatment path. I have heard some incidents where that doesn't appear to be the case, that people are simply going into the system that has been described there as being hugely backlogged, and that there is no real priority being given. And this is, I think, it's very important to bear in mind that these are people who have been harmed by the health system in relation to the care delivered under the health system, and therefore I feel there's an additional duty, and again I'm conscious of the needs of all of our people to get access to services. But are you aware of instances where it seems that people aren't really being prioritised in terms of redress, in terms of the treatment that they need? And I'm conscious here also, I met recently with FND, Functional Neurological Disease Matters NI, and they were saying that a lot of people are coming back into them because they were initially misdiagnosed as being neurological, whereas they're actually functional, and they're now seeing where people are not getting the treatment that they need now to make up their health deficits that have been caused.
Thank you, Chair. I'm happy to pick that question up in the first instance. And it has been acknowledged that the psychological support that is required for these patients due to the distress that they have suffered has been a key factor. And I suppose just maybe it would be helpful for me to go back to explain that the Trust have secured psychological services for all three cohorts to support patients with psychological and emotional issues arising from the involvement of the neurology recall process. Patients are referred through the recall services management team, and the support sessions are completed in collaboration with each individual patient and the family carer where appropriate. Where the Belfast Trust have given the Department assurances that where ongoing and longer term supports are required in terms of mental health or psychological difficulties, that these are discussed and onward referrals are made as needed. I'm aware that the Belfast Trust included an information leaflet for the Cohort 3 recall letters that were issued in relation to the psychological support services. It was sent with the letters to attend the recall. In relation to psychological support, the Department appreciates the requirement for that, given the distress, and access to this support service has been put in place by the Trust to support patients who were affected. It's maybe important to highlight that it the Belfast Trust have given an assurance that this is an additional service provided to support patients affected by the recall that isn't available to others, and that the Trust continues to be committed to support patients to attend the service, the neurology service, and we're involved in the recall process. But I'm aware of also, and maybe this goes into Peter's area, that there is a significant demand for support across all areas in the healthcare system, with waiting lists, which proves to be much more challenging at times. But in relation to the Chair's question, in relation to any concerns that have been raised, the Department has received some concerns in relation to access to psychological support services, and we have sought assurances from the Belfast Trust in that regard on behalf of specific cases and in more general terms. And the Belfast Trust has confirmed and given assurances to the Department that all patients who were invited to the recall have had an appointment with an appropriate consultant, that they've arranged expedited pathways for patients who required any investigations or additional appointments. And this was to ensure that all patients could be provided with the necessary reassurance regarding their condition and treatment. And they have assured the Department that expedited pathways were arranged for all patient cohorts, including the fast track to psychological services at the Trust, that the Trust continues to support those affected through the helpline. So if there is any concerns there in relation to that still exist, the Department would be happy to accept consideration to bring that forward to seek further assurances with the Trust if that's required, Chair.
Okay, thank you, Anne-Marie, and thank you for that. And if there is anything further, I or we will certainly flag that up to you. I was looking to ask then what work the Department has undertaken in relation to a redress scheme, and are there any estimates of how much such a scheme is potentially going to cost? Yep, so can I ask Peter who'll deal with that question?
Again, I think that's probably for Robbie and Anne-Marie. The review itself, the service review, doesn't cover that issue at all.
Okay, so Anne-Marie, I'll go to you first. Anne-Marie, in terms of redress.
No problem, Chair, thank you. I just noticed that Robbie had joined us, so I was wondering whether or not he wanted to cover that point, but happy to cover it. The committee and members will be aware that the Department initiated work in 2019 to consider a potential neurology redress scheme that was announced by the Permanent Secretary in May 2018 to address the rise in compensation issues. A project board was initiated at that time following consideration of redress options in January 2020. There was further work commissioned in order to consider a more streamlined process for neurology patients. The Minister made an oral statement on the 20th of April this year, which confirmed that work had recommenced following the unfortunate suspension due to the COVID-19 pandemic and the need to divert staff resources to manage the response to the pandemic. But I can confirm to the committee that the project board has since reconvened in May 2021 and an update was provided to the Minister on this work in July. It's apparent from this work to date that these are highly complex cases. There has been valuable learning that has been gained in relation to the progression of neurology cases in the interim period, but they are very complex in nature. So I can advise that this work continues, and with the appropriate stakeholder engagement, we will arrange the outcome of that work, which will require approval by the Minister, and the Department is trying to progress that work at the minute. In the meantime, all claims received in respect of care in relation to neurology recall patients are progressing through the normal standard arrangements for health service litigation claims.
Okay, thank you. And then the final one from me before I go to members is so this is going on for quite some time, and there have been a number of common themes that have emerged across a lot of these scandals around governance issues. We saw it in hyponatremia, we see it in Muckamore, in Dunmurray, and also in neurology. And I'm also conscious that we have a lot of ongoing processes, a huge amount of ongoing processes, all of which are appropriate given the scale and complexity of the problem that has been created here and the difficulties that have occurred. But we cannot wait for an outcome for all of these various strands. So in light of that, can you give me any example of something that has already changed, that has been identified as part of the difficulty here, and that has changed to try to support or renew or re-establish that confidence in the governance arrangements within health?
Thank you, Chair, for your question. I appreciate that as the department continues to oversee the various neurology work streams, the assurance group, which is permanent secretary led, continues to oversee this work. And I appreciate the frustration caused by unfortunate delays in the progression to complete these work streams. The department remains committed to doing so and to providing the appropriate outcome as we move forward. In relation to, and Robbie covered it in his opening remarks, in relation to the 4 actions that were taken by the department back in 2018 that the department is currently overseeing, which included one was the establishment of the independent neurology inquiry, and the other 3 related to 3 Rqaa reviews, and as you know, the deceased patient review is in progress, but the other 2 Rqaa reviews have been completed. So the review of governance of outpatient services in the Belfast Trust completed in February 2020 with the publication of that report. This review focused on neurology and high volume specialities. High volume specialities included identified specialities in relation to high volume of attendances, both new and review appointments, and identified specialities in relation to high risk and complex conditions. The department, following the publication, has requested the board and the PHA to assess the broader implications of the recommendations in respect of other trusts and not just limited to the Belfast Trust, and commissioned that work to work with the trusts in order to develop an action plan to put in place the necessary implementation arrangements with an associated timeline. This took place, unfortunately, at the early stages of COVID-19 as organisations moved into contingency planning, and as a result the board wasn't in a position to take forward that action. But the board has informed the department that it is currently reassessing this request and will re-engage with the Public Health Agency and Rqaa in the matter, and the department expects an update on that work in the near future. So that's one review that has been completed, is in the process then of hopefully being able to see improvements being implemented. The other completed review of Rqaa is the review of governance arrangements in independent hospitals and hospices, which was completed in June this year, so it's relatively recently completed. As part of the programme of this work initiated in response to the standard of care provided by Dr. Watt, Rqaa was commissioned by the department to undertake a review of governance arrangements in the independent hospitals and hospices. In partnership with an expert review team, Rqaa visited each of the independent hospitals and hospices in Northern Ireland as part of this work, and undertook a comprehensive assessment of the governance systems and processes to ensure the delivery of safe and elective care. So the report that was published in June 2021, the key findings from the report covered specific areas in relation to internal leadership and accountability, components of effective governance systems, and linkages to the wider HSC system. The Rqaa report makes 20 recommendations to bring about transformation and improvements to the governance arrangements in independent hospitals and hospices, and the department is currently considering recommendations and developing an action plan to respond to those that have been accepted. I don't have any further information in relation to that, Chair, but if it would be helpful, the relevant officials within the department may be able to provide a further update to you in relation to those 2 reports, which may be helpful.
Okay, yes, and thank you, and I do appreciate that, because I think it's important that these processes are dynamic in the sense of when learning is gleaned and established, then we should move to implement it as quickly as possible. So appreciate that. So I'm going to go to members then. I'm going first of all to Deputy Chair Pam Cameron, then Carol, Jerry, Deborah, Paula and Colin. So go ahead, Pam, please.
Thank you, Chair, and thank you, panel, for your attendance at committee today on what's an extremely distressing issue for so many who have been affected by this neurology scandal. I have a few questions for you, but I just wanted to tap in first of all to the issue of the helpline. And I mean, even as we are hearing from you today, I'm getting feedback from patients who don't feel like they're being engaged with. They feel like the helpline doesn't actually work the way it should. So I think it's really important the department does understand and recognise how patients are feeling, and it's really important that patients are consulted regularly and that they do see movement in terms of the redress scheme and see that actually somebody out there actually cares about the harm that has been caused to them. So I suppose what I would ask of you first of all is what else is there out there, or what can be done over and above the helpline that's already there to ensure that these patients actually feel like they are being properly engaged with? And can you also outline if there's any further information on the timescales on that progress of the redress scheme, and how quickly will patients actually see some kind of outcome? That's my first question.
Thank you, Pam. In relation to the issue that you raised in relation to the neurology advice helpline, I'm aware that patients phone the advice line for a variety of reasons. Some patients request copies of their medical records. Some wish to talk about their recall experience. I think in more recent times, I understand that former patients of Dr. Watt have used the advice line to access information relating to the structured judgment review of the blood patch procedure that they had performed. We're assured and will continue to seek assurance if that would be helpful from the Belfast Trust on any issues that are encountered in relation to that. And similar to the access to the psychological services, any concerns that have been raised with the department, we've actioned that by seeking assurances from the Trust in relation to confirmation if there is an issue, how that is due to be addressed. To date, we've received assurances that there has been no issues in relation to the advice line, that the advice line is open 9 to 5, Monday to Friday, with the exception of bank holidays and public holidays. The Trust have confirmed that they have a dedicated staff resource who has responsibility for answering that phone line, and that the phone line is not left unattended. And out of hours, there's an answering machine available to receive calls, and calls are then returned the next working day. But we will continue to seek assurances as required as issues arise, member, and happy to do so. In relation to the redress, unfortunately, I can't give a definitive timescale for that because the work is continuing at the minute and it requires ministerial approval on that work. But I can assure members that we are working hard to try to come to a point where the outcome of that work can be made public.
Okay, thank you for that, and I'll probably follow up with you with more consultation with patients in terms of the helpline and what's available there and what the issues are. If you don't mind, I'll come back. I'll maybe write to you on that. I wanted to ask as well. Do we know when the Cohort 3 recall results will be published?
The current position on the Cohort 3 recall is that the recall has been completed. So everyone that was recalled has had an appointment and the outcome of their appointment. The information as a result of that recall has now been passed to the board to compile the Cohort 3 outcomes report. So I understand that the current position on that is that it is in development, and we will work and liaise with the board to try to establish an indicative date for the publication of that.
Okay, and do you see that as being weeks, months away? Any rough indication?
Hopefully in the next couple of months, I would say, if being pressed on that, but please don't hold me to that, because it is somewhat outside the department's control in relation to making sure that all details are verified and cross-checked and everything else, but hopefully in the near future.
I appreciate that, Anne-Marie. And another question for you. I wanted to know, will the department, on behalf of the Minister, guarantee that patients see the independent inquiry report before it is released to media and to the public?
I'm sorry, I can't provide you with an answer on that, but happy to pick that up in writing, Pam. I'm just not sure of the current position and the appropriate response to give you on that, but happy to take that forward and confirm the details in writing if that would be helpful.
That would be very helpful, thank you. Thanks, Chair.
Okay, thank you. And just to let the panel in particular know that Robbie is back online on the mobile phone. If you need to go to him, we don't have a picture, but he is there and access via mobile phone. So I'll go then to Jerry. Sorry, I had Carol first, and then Jerry, then Deborah, Paula, Colin. Carol?
Thank you, Chair, and thank you, Anne-Marie, Peter and Robbie, for coming in front of the committee this morning. The Minister has declined to meet with some of the neurology families under the voluntary erasure, which is really disappointing, given what we've just discussed this morning. It's added to just the overall disappointment in this whole process. I wonder, could you tell me how many times Michael Watt was referred to the GMC on the fitness to practice? That's my first question.
Robbie Davis here. Thank you for that question. I do not have to hand that level of detail. My colleague Anne-Marie may have the answer to that, so I'll pass to her in a second if she does. But by way of expanding on your previous point, the department has engaged and will continue to engage with patients and families and support groups and others as appropriate, and arrangements are already in place, as has likely been covered through the course of the conversation with the patient and client council to ensure effective communication with patients and families is fluid and continues to happen. I know the Minister has made a number of announcements in the past on these issues, and I expect at an appropriate juncture he will want to engage further with patients and families affected.
So in relation to the fitness to practice, Anne-Marie, do you know how many times Michael Watt was referred to the GMC?
I'm sorry, Carl, I don't have that information. Again, we can check with officials in the department, but I suspect because the GMC investigation is independent of the department, that the department may not hold that information, but happy to check with officials in the department for you. Okay, and I suppose further to that, I mean, in relation to the number, are you aware of any ongoing or pending inquests or PSNI investigations into Michael Watt's care, particularly of the 45 deceased patients? So that's one question. And then the other one I would have is just, you know, like, I'm not being pedantic, but the Minister is the department, so has the Minister or the officials advised the Minister on what the views are regarding Michael Watt's voluntary erasure by the NPTS? And my last question is, should Michael Watt be allowed to keep his pension from the Belfast Trust? Thank you, Chair.
Thank you, Carol.
Thank you. I will pick up on those points in turn. Firstly, in relation to a PSNI investigation, I'm not in a position to comment on any police investigation, as that would really be a matter for the PSNI to provide an update on. So apologies, that's not something I'm really able to furnish you with much more information on. In terms of the voluntary erasure of Dr. Watt from the register, The department shares the disappointment of the GMC at the decision of the tribunal. It's very regrettable, and I know Minister has made it be known that he was disappointed at that outcome. Unfortunately, the department had no role in the decision, and there is no avenue of appeal open to the department to reverse or alter the outcome. As we heard in this morning's sessions from GMC, unfortunately, it doesn't sound like there is a reasonable prospect of a judicial review being taken by the GMC that would have any prospect of altering the outcome regarding the voluntary erasure. And on your final point in respect of Dr. Watt's pension, I understand as Dr. Watt has retired from the Trust, in line with the terms and conditions of his contract, I understand the grounds for reduction in benefits or forfeiture of pension have been assessed, and at this point in time I understand they haven't been satisfied. However, if new information comes to light as things progress, there would be opportunity, I would assume, for that to be reviewed.
Chair, can I just seek a bit of clarity? I didn't ask Robbie the details of the PSNI investigation. Just to be clear, I asked, is there a PSNI investigation? Surely that's something you could say.
I do understand that complaints have been made to PSNI by either families or patients. So my assumption would be that PSNI have an investigation or have had an investigation.
And are there any pending inquests into the 45 deceased patients under Dr. Watt's care, do you know?
I'm not aware. I will ask Anne-Marie if she is aware, but if not, we're happy to review that and provide an update following this.
Yes, Carl, I can confirm that we have no details, no further details in relation to the PSNI investigations or inquiries, and that would be a matter that would need to be directed, probably more appropriately directed to the PSNI themselves in relation to any investigation or follow-up that they're intending to take. But that the department, if approached, will support any investigation on those terms. To support anything going forward. Okay,
thank you, Carol. Just checking quickly back with you there before we move on.
Yeah, there's no awareness of any inquests into the 45 deceased patients' circumstances of their deaths.
The deceased patient review, as you'll be aware, is being taken forward by Rqaa, who may well be able to have more detailed information on that. I understand that they've provided a written briefing to the committee. I'm not sure whether it's arrived today or prior to today, but if not, I understand it's on its way, and that might provide the opportunity and the detail that the level of detail, Carl, that you're questioning there.
Okay, just to confirm that hasn't arrived, but we will look at it when it does. Okay, I'm going to move on then to Jerry.
Thanks, Chair. I mean, obviously, first and foremost, our thoughts are with the victims, but in terms of this scandal and inquiry. But wanted to ask what the department's assessment is on the long-term effect on neurology generally, and the department obtaining more neurologists and people coming forward who have neurological conditions with the issues relating to this crisis.
Thanks for that question. I'll maybe take a start on that. Yeah, it's something we're aware of, member, and it is a concern because, as I said in my opening comments, we need a lot more neurologists to cope with the demand that we're seeing today and what we'll see in the future. So that is a concern. There are steps being taken to try and improve and enhance the numbers of doctors that are going into training. So we have currently 11 neurology training places, but there's only 7 of those are actually filled at the moment. In NIMDDA, they hope to increase the interest in neurology by providing further access to the subspeciality and through this foundation program. But as you say, I mean, with the I suppose this reboot that's been handed down to on neurology, especially, that'll be a challenge for sure.
Okay, I mean the fact that the pack from the department states that a neurology specialist can't see adults in a neurological emergency within 24 hours of admission isn't currently possible is very, very concerning. I think there's urgent work needs done around that, and it's connected very much so, I think, to the inquiry. I have a couple of questions, so I just have to move on through them. Has the Department of Health written to NPTS to question its decision to let Dr. Watt step aside without any tribunal or challenge? And can the department initiate a JR? We heard that the GMC aren't going to proceed with the JR, but can the department issue a JR, and have they considered or discussed that?
Thank you for your question. As I had probably said earlier, the department shares the disappointment of GMC at the decision of the MPTS to allow the voluntary erasure of Dr. Watt from the register, and we appreciate and acknowledge the distress this will have caused to patients and to families regarding this recent announcement. Unfortunately, the department has no role and had no role in the decision, and we do not have an avenue by which to reverse or alter the outcome. I think reflecting on the evidence provided by the Chief Executive of GMC to the committee this morning, when he felt that there was no reasonable prospect of success for a judicial review based upon the legal advice they had received, and highlighted the impact that pursuing a judicial review under those circumstances and in that knowledge might have on families and patients, that in all practical reality there isn't really much possibility of a judicial review of the decision.
Okay, so if I heard you correctly, the department can initiate a JR, but they decided not to. That's my reading between the lines, if you will, from that answer, and that's very disappointing. I think it's important as well, as Pam said, that the department does issue the report before it's released to the inquiry report, before it's released to the public and the media. That's imperative in my opinion, and I'm sure other members of the committee. In regards to the appraisals of Dr. Watt that didn't happen, how many people in the trust were responsible for the appraisals of Dr. Watt not taking place?
If I could perhaps pick up on both points there. Firstly, in terms of the inquiry report, I think it's worth emphasising that the independent neurology inquiry is independent of the department, and how they handle the report is at their discretion. But I do absolutely take on board the point you make, and I'm sure that's something that the neurology inquiry will be taking on board, but it's not something that the department would have discretion over. Apologies, I think I missed the second element of your question.
The number of appraisals were missed. Dr. Watts, a number of his appraisals were missed for several years, as I understand it. Who was responsible? How many people were responsible in the department for not ensuring those appraisals were carried out?
Appraisals of medical staff, to my knowledge, would not be within the role of the department. I'm assuming that would likely have fallen to the Belfast Trust, but apologies, I would probably have to come back to you to confirm as to who specifically that question should be addressed to. Okay,
just finally on that, has the department considered conducting its own investigation into Dr. Watt's practice generally, and the fact that his appraisals weren't carried out, especially in light of the MPTS decision and not to proceed with the tribunal?
I would highlight that the MPTS decision has been taken very recently, and the current priority of the department is to support the fulfilment of all existing neurology work streams that are underway. Once again, I would reiterate the department's disappointment at the decision of the MPTS, and that it is very, very unfortunate, but there is very little the department can do to alter the outcome.
So is that a no to my question? Presume so.
I'm not aware of any work in that regard at present.
Okay, some disappointing answers, but thank you, Chair.
Okay, thank you, Jerry. Deborah, go ahead, please.
Thank you, Chair, and thank you to Robbie and Anne-Marie and Peter for coming today. Obviously, behind everything that we're talking about are families and victims who have been let down. And it's important that we're able to get some full answers in relation to what has happened. I mean, just following on there from the question, a lot of people will wonder, who then is going to investigate Dr. Watt's practice, and would it not be in the public interest and in the interest of justice that the department even carry out their own investigation? And can they justify not doing so?
Well, first of all, I would just like to reiterate that the department recognises the hurt caused to the patients and families affected by the neurology recall and acknowledges the frustration that patients and their families will feel at recent developments. I would also highlight again that the Minister has unreservedly apologised to the patients and families affected for the upset and distress caused. The department is committed to rebuilding and restoring confidence in our health service, and at the outset we gave an overview of the 8 various reviews that have taken place and are underway with regards to the neurology recall, and the department is committed to ensuring that lessons are learned and implemented to effect the necessary change.
Okay, and I think Carol had asked a question there in relation to Dr. Watt's pension. I'm not sure if it was answered, but I mean, Dr. Watt does have a full pension from the Belfast Trust, and is the department able to revoke his pension considering the millions of pounds that the recall has cost and the thousands of pounds that will be spent in settling litigation cases?
Yeah, I'm happy to go over that. Again, Dr. Watt has retired from the Belfast Trust in lines with the terms and conditions of his contract. I understand that the grounds for reduction in benefits or forfeiture of pension have been assessed, and at the point in time at which they were assessed, there were not grounds for reducing or forfeiting the benefits. I would just add to that could be, in theory, reassessed and reappraised should more information come to light that would justify it being revisited.
Okay, thank you.
Thank you, Deborah. And going to Paula. Go ahead, Paula, please.
Thank you, Chair. Thank you, panel, for coming before committee today. I suppose that my question was going to be around the redress scheme, and as Colin alluded to, we as elected representatives were advised in the summer of 2018 that the department didn't want to see the people who've been affected by Dr. Watt's practice to lawyer up, which were the words that were used at the time. And I'm very concerned that 3.5 years later we are still no further forward really in terms of a redress scheme coming forward. And I just want to know how much you've engaged in with legal services or parts of the judiciary in terms of how it will be structured in terms of the severity of the impact on the patient and their families, and then as Carol and others alluded to, there are those that are already deceased. So I just want a wee bit more information around this, because these redress schemes are meant to compensate quickly and fairly for the damage, and I don't think that we're seeing any quickness at all here. Thank you.
Thank you for your question, and I understand the point you are making. I'm happy to provide an overview on neurology compensation, and my colleague Anne-Marie may jump in with a bit more detail. The Department initiated work in 2019 to consider a potential neurology redress scheme to address rising compensation issues. A project board was initiated, and following consideration of redress options, in January 2020, work was commissioned to consider a streamlined process for neurology patients. The Minister's oral statement on the 20th of April this year confirmed that this work had recommenced following the unfortunate suspension due to the need to divert staff resources to manage the response to the pandemic. The Project Board has since reconvened in May 2021, and an update was provided to the Minister in July. It is apparent from the work carried out to date and the valuable learning from the progression of the neurology cases that the neurology clinical medical negligence claims are very complex and challenging in nature. Work continues, and the appropriate stakeholder engagement will be arranged in order to support the outcomes of this work. In the meantime, all claims received in respect of the care provided by the consultant neurologist have been progressing as quickly as possible under the standard arrangements for health service litigation claims.
Thank you. Anne-Marie did read that out before when you were offline, so I do appreciate the sort of official response to it. But my concern is that there are a lot of the patients who have had to go and seek their own legal representation and are having to pursue these cases, adding to the emotional, psychological distress that they're already experiencing, not least the fact that many of them are very seriously ill. We really shouldn't have had to have this delay that would push people down that very legalistic route, and so really disappointed with that. But I'll move on. The second part of my question is in relation to the workforce, and this time about 14, 15 months ago, when the Minister announced the management board around the re-establishment of the health system, but when he dismantled the Transformation and Implementation Group, he said that he was going to, when they put back the health service, they were going to bring forward the transformation agenda at the same time. I am concerned that there are huge vacancies, huge pressures on the existing workforce, and I'm just wondering to what degree are we going to see some sort of regional model coming forward to actually be able to provide patients with timely consultants appointments, because I would imagine that the Rqaa has impacted greatly on waiting lists for those people who are just entering the system in the last few years. Thank you.
I'm happy to pick that up, member, if you don't mind. In relation to the staff resource put in place by the Trust to support the Cohort 1, 2 and 3, that was additional clinics and staff that were put in place to make sure that existing provision wasn't impacted, or that the patient that's being recalled weren't disadvantaged in any way as a result of the recall. But in relation to, so I can give that assurance that those measures were put in place by the Trust. In relation to transformation, I apologise, but that's not my area of expertise, and we would need to seek some more information for you on that, on the broader sense of transformation and the existing, plans for workforce issues going forward.
I can maybe try and pick that up, Anne-Marie, at least to some extent. Neurology workforce specifically is part of the review that we are currently taking forward. So that will obviously look at the amount of workforce we need going forward. There has been investment very recently in additional consultants. So there's funding of 144,000 this year, rising to 248,000 next year to fund 2 new consultancy places in Belfast and Northern Trust. So that investment is there, and as I mentioned in my opening comments, that we know that there is a significant gap between the amount of neurologists we have and what we need. As I said, there are 11 training places at the moment, but only 7 are filled. So we need to do more, obviously, to make sure that those training places there will be filled, and we need more training places, frankly. So that's something the review will also look at, and I'm absolutely sure we'll be getting to that as part of the future budget process. But this takes time, unfortunately. It takes 10 years after somebody has finished their medical degree to actually qualify as a neurologist consultant. So there's probably no quick fix to this, unfortunately, but it's something that we need to invest in, and we need to invest in it quite heavily.
Thank you. I appreciate that it's not an easy issue to deal with. I suppose my concern is, again, not to preempt what the inquiry will come up with, but a lot of the issues in relation to Dr. Watt and the other consultants is the amount of cases, the caseload in front of them. And I'm just wondering, as Anne-Marie had indicated there, that when you needed to buy in additional resources, the funding was found and the resources were put in place. And I'm just concerned that we could potentially be seeing another one of these cases where a consultant has just got far too many cases in front of them, and that critical information could be missed in relation to patients' cases. So, what are you doing about that in the interim while you build up the capacity of the consultants?
So there is a process underway to review the waiting lists. And there will be some people on that waiting list that's been there for many years, and some of them will not need an appointment anymore. So there's a few to board, there's a regional process in place to review waiting lists across all specialties, including neurology, which will hopefully then at least remove those patients that no longer need the treatment to be seen. That obviously not going to solve the problem, because there's still going to be a long list still of patients that we've seen. The other thing we're looking at is through the reviews care coordination, so trying to coordinate the care better, so those that need care will be seen in the right place the first time, to try and avoid people being sent around in a merry-go-round, so that they know at least they're getting the right treatment, the right assessments first time. And we're also looking at the nursing workforce. So we're looking to expand that, and to expand the role of our neurology nursing workforce and grow that to also try and take on some of those pressures. But as I say, I really don't think there's a really quick fix here, unfortunately.
Okay, thank you, panel.
Thank you, Paula. I just want to quickly check with Colin. His hand had been up there, but I want to check, Colin, are you looking in for a question, or can you hear us okay there? We're not hearing you, Colin. Can you just check your mute? We're not hearing you.
Yeah.
Yep, go ahead.
All covered at this stage, thank you.
Okay, thank you. And then I'm going to go to Alan.
Thank you, Chairman. Chairman, there's certainly been a lot of talk about Dr. Watt's pension and a sense that he should be deprived of it, and I can't disagree with that at all. But in relation to, I feel that no corners should be cut in funding the public inquiry, and not one penny of compensation that patients may subsequently seek should be begrudged to them. But it does worry me that this is going to place a huge strain on the public purse, and it's the actions of Dr. Watt that has precipitated this, and certainly taking his pension off him may look like optics, but it is not going to go anywhere near recompensing the public purse in this. So my question would be, is there any potential subsequently, when this is maybe all wrapped up and over, for civil action to be taken against Dr. Watt to recover the costs of the public inquiry and any compensation that's paid out? My understanding is that medical practitioners carry medical insurance to cover themselves for such claims by made individually against them. And I'm wondering, does Dr. Watt, or did Dr. Watt have that indemnity supplied by an insurance company that he would have paid a premium for? And also, or is it the case that the Trust and the Department of Health sort of have indemnified him and that they have to pick up every penny of compensation that has to be paid, and he walks away scot-free? So just could somebody tell me, is there a potential for civil action to be taken against Dr. Watt to recover the costs of all this? Thank you.
Alan, thank you for your question. And yes, certainly in terms of compensation and the costs of the inquiry, there will be significant sums involved. That's certainly the case. In terms of Dr. Watt's indemnity insurance, I am not aware of what he may or may not have had in place, and unfortunately I'm not in a position to answer that. Certainly there will be a distinction between trust and private patients and separate processes for pursuing clinical negligence claims.
Would this be an avenue that your legal team will be prepared to examine and pursue? I wouldn't like to think it'll just be left dangling there because we don't know the answers. I think it's an important potential to explore, and I think it would be in the interest of the public purse to explore that. And that if he does carry, I'm sure he carries medical insurance. He must do, because I understand all practitioners carry it. I don't know whether it would be included in his contract with the trust, whether he has to have medical insurance, or whether the trust, as I say, in the terms of his employment, whether they provide that indemnity themselves, which I think would be a shame if they did. But are you prepared to ask your legal team to explore this? Because I think there's got to be a potential for at least a possibility that there might be an avenue to retrieve money from his insurers.
Thanks again for the point you're making, and certainly all issues relating to compensation and redress are under active consideration, and we do hope that we'll be in a position to share our thinking on that in the near future, and engagement with patients and families will certainly be one of the key aspects in that, in ensuring it meets everyone's.
Can I just reiterate that my comments here, as I said at the outset, I don't begrudge, and we shouldn't begrudge, one penny of compensation to the patients who have had to suffer at the hands of Dr. Watt. And my questions around this are in no way a reflection on what compensation will be paid. They fully deserve every penny they'll get. Thank you.
Yeah, thank you, Alan. And I think that is because I think I actually agree with your point there that while none of us would begrudge for 1 second that payment, the fact that the impact on the health service here is likely to be massive as well is something. So I think that is something, and maybe we should seek some further information on that in writing, if committee members agree. I think yeah. Thank you. Carol, I see your hand raised there. Did you want to come back in briefly before panel? Before I let the panel go? Yeah.
I do. Thank you, Chair. It's just for the panellists, and I just wanted to check there. Jackie Johnson attended the committee on the 30th of January this year with the Permanent Secretary, Richard Pengelly, and he did say that there was ongoing criminal investigation. So we do need clarity on that. But what I would like, Chair, if the members are happy, and I completely agree with everything that Alan has said, by the way, but what I would like to do, if the committee are happy, I think we do need to write to the PSNI to ask if there are ongoing criminal inquiries, investigations, into Michael Watt, and have that shared with the committee. Thank you.
Thank you, Carol. Yeah. Yeah. Okay. And I think I have to say that there's a commitment from you, and there has been a lot of information shared, and a commitment from you all to send on some further information, which I welcome. But there are also a lot of unanswered questions, and I think families have to be deeply concerned at the level of lack of clarity on some of these issues. So I do think it's important that we continue to provide a focus and to continue to keep a very watchful eye on what's unfolding in relation to this very, very difficult and massively impactful issue, given the scale and complexity of the harms that have been caused. Okay, listen, I want to thank the panel for coming along this morning and for addressing members' questions and for your presentations, and to wish you all the very best in the time ahead, particularly in relation to your work on this issue. I think it's very clear from both the sessions we've had this morning that there's an awful lot of work still to be done and an awful lot of harm and redress still to be addressed by the system around this issue. So thank you for that, and then I'm going to go ahead back to members to just a couple of other issues to discuss in relation to this, but I can let the panel now go. So thank you. Okay, members, I want to come back there first of all, and then I'll come to members for thoughts, but I want to come back on a couple of bits and pieces in relation to the neurology more widely. In terms of the written briefing that was presented from the inquiry panel and the letter declining to appear before the committee in closed session, and I have to say from the outset that I think that's very disappointing that the committee, and I know the committee have appeared, the inquiry have appeared here at committee before, and I think did provide some reassurance to families in committee session that they understood the problems that families were experiencing and that they were engaging with them. And I think it would have been better. I do recognise that they are coming towards the end of their process, and I welcome that, and I do understand that there are processes to be gone through. But I think it would have been preferable, I still think it would have been preferable had they briefed the committee even in closed session. My first preference would always be open session, but I just want committee's views on that. They are still saying that they will brief the chair and deputy chair, so members' views on that, please, just or anything else coming from the session there that we've just had. I'll take a view from members. Yes, I'll check with Pam and then I'll come to Carol.
Yeah.
And then Paula, yeah. So Pam.
Thanks, Chair. Sorry, you broke up an awful lot there. I didn't get a while of it, but just picking up, obviously, the inquiry panel we did, and I had proposed that all of committee be included in that closed session, if that was all that was available. I think we understand some of the sensitivities around the issue, and I suppose while it is disappointing, we wanted the whole committee to be involved in that, and we would prefer it to be in public, but if that's not available, I think we have to take what is available and meet as chair and vice chair at this stage.
Okay, Carol?
Yeah, I mean, I agree with Pam. It is a pity that the committee even couldn't, or the inquiry, sorry, couldn't meet us in closed session. I just think given the interest that this committee's played, and we've all been very, very respectful and remain very respectful of the process of the public inquiry, particularly because it hasn't concluded. But just to support Pam and Callum going to meet the inquiry, I think if they don't have it already, all the questions that we've raised, including transcripts, should be forwarded on to them. And I would like to see, if possible, when the committee, or sorry, the inquiry will conclude and come in front of the committee at a later stage. And Chair, it's just to ask for clarification, have we made an agreement to write to the PSNI regarding ongoing police investigations into this matter?
Yeah, I think there was broad support. I'll just double check again, but I think committee are content to write to PSNI and ask about any ongoing, just to establish whether there are ongoing. Committee are content with that, Carol, yes. Paula?
Thank you, Chair. I'm happy to support yourself and the Deputy Chair going to meet with them privately, but I have to say I'm bitterly disappointed. Some of us were involved way back before the public inquiry, supporting the panel and encouraging patients to come forward and present, who were very hesitant and reluctant to get involved, and we did a lot of work in terms of supporting them about how they could communicate and extract information. So I think it's actually really insulting to the work that we put in, all the political parties put into facilitating the contact between themselves and our own constituents. So I'm very disappointed, I have to say. I thought better of them, but I think you should go forward and meet with them individually, or sorry, in your capacity as chair and deputy chair.
Okay. Okay. Thank you. Okay, Colin, go ahead.
Chair, just a simple comment. I've always felt in the public that if you do something in private, it's just to hide, and it's to maybe put on record. That's the impression that will go out to the families, and that's the impression that will go out to the public, and that it's not this committee that wants to do that in private, it's the inquiry team. So just to make them aware, that's how this will go down with the public, that they've got something to hide, so they'll just have to deal with that.
Okay, thank you. So listen, I think there is broad support from members that we do that on the very clear understanding that that is far from our preferred approach to this, but that we will go ahead with that. Okay, members.
Could I just
yes, Alan. Go ahead, Alan, and then very briefly, Alan first.
What reasons have they given us for refusing to meet with us, either in closed session or public session? What's the rationale?
Yeah, I'll just bring the clerk in on that.
Yeah, thanks, Chair. Just the outline. Sorry, I'm heading into the response. They did highlight a few reasons. I'll just read them out. First one, that they thought there was nothing that could be usefully added to the written briefing provided without straying into sensitive issues, which will be properly discussed in the report or outside the terms of reference. The second was the inquiry has reached the sensitive part of the process, and the Maxwellisation process is due to commence at the end of October. The third one was the patient group has been kept informed of progress, and the responses received indicate that they were reassured. And fourthly, as a statutory inquiry, it is required to maintain independence and work within a statutory framework. So they have outlined issue or some of the reasons within their response, which is at 5.2 of the pack. So you'll be able to see a wee bit more detail around that, but they're the sort of the high lines of the reasons why.
And just in light of that, actually, that's another thing that I thought would be useful, members, if members agree, that we publish all of the written briefings received, including that the briefing from the inquiry, that we publish that all on the committee's webpage, in a sort of separate area, and all of the various briefings we've received, that we publish those, and we also link in the Hansard, so that members of the public and families in particular, and patients and most of all, will have access to that information in an accessible way. Would members agree with that?
Agree, Chair.
Yeah. Members agreed. And also just to advise members that we are getting briefed by Rqaa on Tuesday at 12:45 in room 30. We had wanted to speak with Rqaa in relation to this as well. Hadn't been possible today from the Rqaa side, but we will be picking up again on Tuesday with the Rqaa in an additional meeting to cover that element of the neurology inquiry. So, members, I think there's a number of actions there indicated and that will be useful. Pam, I see your hand up. Is that from the previous? Yeah.
No, Chair, it was just to check that we have agreed to write to UK Parliament,
yes,
to the Health Committee at UK Parliament on the issue as well.
Yes, that was agreed by committee. Yep, that was agreed.
That's great.
Yep.
And I just wanted to check as well, maybe we should go back to the neurology inquiry and just make a last-ditch effort to have the entirety of the committee included in that closed session, and feeling that if that doesn't work again, then we go ahead with yourself and myself.
Okay, members agree with that. I agree with that approach. Are the members content with that? Yep. Okay. Okay. Thank you, members. We'll action those particular steps, and as I say, we're coming back to it again on Tuesday via Rqaa. Okay, members, so we are now moving to take the next two agenda items in closed session. So I'll just ask the clerk to end the broadcast. Yep. Thank you, members. Moving on to item 9, which is in relation to the Health and Care Bill on the Legislative Consent Memoranda. I remind members that the Health and Care Bill was introduced in Westminster on the 6th of July and that the committee was briefed by departmental officials on the provisions of this bill that require the legislative consent of the Assembly at our meeting on the 14th of October. The committee requested further information in relation to a number of issues, and the department's response to those requests is at tab 9.7 of the table papers. Also included in your table papers at tab 9.8 is a copy of the letter from the Department advising that it has changed the wording of the motion for the third LCM. So in relation to that, I'm going to go to members to see if members want to raise any issues of concern in relation to those. I do want to, I suppose, just say generally that I feel that these are often a matter of some concern in that you don't know what's going to happen in the future, but we can't, I suppose, future-proof it. However, I do think that in relation to LCMs, there has been a bit of a kind of a trend of a lack of consultation here locally, and I think that's an issue that we certainly should continue to flag and continue to press for improvements. And I think that if any changes are going to be brought forward as a result of LCMs that we're discussing here today, that there should certainly be a robust and an effective consultation process here in relation to those elements. So, Jerry.
So on that, those 100 organisations are all in Britain, I take it, the ones who were consulted?
I think there was one, maybe, was there? From memory, I'm not quite sure, but I think there was. But I know it often is quite a small number, and that flags up a concern, I think, a weakness in that type of process. Clerk is checking that. Any other views from members in relation to the LCMs? No. Okay.
Chair.
Yes, Pam, go ahead. Yeah.
It's more the two papers. There's a couple of blank pages. I'm not sure whether we're missing something.
Sorry, Pam. It's sometimes the way the department sends the document to us. The blank pages look as though they're the back of the page. It's the way it's scanned on. So it is. So we've been assured there's nothing missing.
Okay.
But I know when you look at the blank page, you can almost see a faint writing. That's because it's the back of a scanned document.
Okay.
So I've been assured there's nothing missing.
Thanks, Keith.
Okay, well, in any case, Clerk, and can we reflect that concern around the consultation process, particularly when some of these LCMs would start to become actioned, if you like? I think that's something that we want to flag up. But I'm checking just if there's any other issues or members. Yeah, Pam, Carol, was it?
Yeah, sure. It's just that, see, this was raised at a couple of different committees and thinking of procedures in the CLG, but the LCM, the difference in the recess times is something that I know is going to be raised by officials in Westminster, because the recesses are different and it has a greater adverse impact on us. So if we could just, as an aside, not impeding this process on the LCMs, but just if you could tie in with Stella McCartney and that to find out, or Stella McCardle, to find out what the situation is regarding the recesses.
Yep. Committee content with that, and Clerk's indicating that can be done. Yep. Okay, so then, members, if there are no other issues, then are members content with the LCMs? Yep. And a short report on the committee's consideration of the LCMs will be drafted for next week's meeting for approval. So just to flag that to members. Okay, members, so I'm going to go on now to correspondence. There's one item that I do want to flag up to members today, and that is item 10.1, which is a reply from the PHA in relation to care homes guidance, and it was in response to an issue that had been raised by Chasney in relation to concern. And again, I had indicated, and I just wanted to declare an interest, that I had spoken to the gentleman at the centre of that case and was quite concerned. There has been some progress in the sense that the department have now indicated that they are moving to step 2 of the guidance, and I think that is very welcome. And I think I'm glad that has taken place. However, I would ask, maybe with committee's agreement, that we forward the response on to Chasney, just to clarify with them that they are content that the matter at hand has been addressed satisfactorily. Would members be content that we do that?
Agreed, Chair.
Yeah, thank you. I don't have any other issues in terms of correspondence there, but if members have any other issues they want to raise in relation to the correspondence on the main pack? No, I don't think so. So are therefore our members otherwise content with the actions as noted on the correspondence list? Yeah, members content, thank you. In terms of the forward work programme then, there's no table issues and table papers to be raised there in correspondence. So in terms of the forward work programme, I refer to the tab 11.1 of the table pack. And can I draw members' attention to the meeting on Tuesday the 9th of November, which is starting, that's next Tuesday at 12:45. So that's 12:45. I would also draw attention to the fact that we're starting at 9 a.m. next Thursday. And we have previously agreed that we are going to meet virtually next Thursday, as the Speaker is using, as requested, and we have agreed that the committee is, or the Speaker is using the Senate for a remembrance service next Thursday. So just to flag that we're fully virtual next Thursday, but we are starting at 9 o'clock. So are members content to note all of that? Mm-hmm. Yeah. And members, we discussed the possibility of an informal session for members on the current adoption process, and we have arranged some of the leading social workers involved to take members through the current adoption process, just to give us some context in relation to our consideration of the adoption bill. That informal meeting will take place via Teams on Friday the 12th of November at 9:30 a.m. and shouldn't last any more than an hour. I'm very conscious that members are heavily committed to constituencies on Fridays, but if I could ask members to make some space for that briefing, given the pressure the committee is under, the clerk will issue invites to members in the next couple of days for that engagement. Thank you. Okay, members, then, any other business then? Carol, I know you had indicated you had something there in any other business.
Yeah. So, Chair, just to advise the committee, because we're currently working through the Adoption and Children Bill, we're currently working on an amendment which hopefully will receive cross-party support, and it's basically on safeguarding against the deletion of records in relation to adoptions. So if, just in advance, if we could ask the Minister if he is considering an amendment of this nature himself before the committee would do it, or even an individual party member would do it, it would be good to get that clarity in advance.
So would members be agreeable that that committee would write to the Minister and seek that clarification?
Chair?
Yes, Paula?
Thank you, Chair. I know that the Birth Mothers and Children for Justice and the other group that's been being set up around the adoptees are very keen to see this amendment put into the bill. So I suppose they should be really at the heart of developing that. So I would support Carol's recommendation, but I would also encourage then that his departmental officials engage with those people who've been so directly affected by the process. Thank you.
Yeah, and I am aware that Linda Dillon, MLA, has engaged, I think, with families and with the Bills team in relation to the potential, and that's where the request is emanating from, that we would seek some clarity, just to check if the department are considering that themselves. Okay, members content with that? Any other business, members? Okay, no. Well, listen, thank you, members, and I appreciate your attendance and your contribution today. A very important session, I think, today in terms of the neurology issue that we have been focusing on today. I certainly want to end the meeting by once again extending our solidarity to all of those people who have been impacted, and to assure them that we will certainly do everything we can to continue to place a focus on this issue in terms of what's being done now, what's happening in the future, and in the interests of transparency and accountability and improvement that we all and that so many families want to see. But I thank members for attending, and I look forward to seeing you all again then on Tuesday for our additional meeting next week. Thank you. Thank you.
This is the Northern Ireland Assembly Senate.